One more country. Today we're going to have one more country presentation from Togo. Um, and then if you have any more questions, please note them down. We're going to have our last panel discussion where we'll be able to discuss more questions and then the ideation so that we can bring all the challenges that have been said to be able to think about solutions and a way forward. And then we're going to wrap up with the learning from the Hexa tools. And we're aware that some people want to, it would be nice for them to leave early so that they can explore Cape Town more. So for that to happen, let's try and keep time. And we'll try to keep our break or coffee breaks very short and tight. Is that fine with everyone? 10, 15 minutes? Is that fine? Instead of 30 minutes, can we 10, 15 minutes? Which one, 10, 15? 10. And lunch break? Can we keep it 30 minutes? Remember, if we all work together and we do keep time, then that will be great for all of us. So just string somebody along who's taking more time than they're supposed to, because it's nice for us to leave early. All right, and also we want to take a group picture, so we're hoping that we can utilize one of the breaks to do that, right? Because we can see that not everyone is here at the moment. All right, so I'm going to call on Bronte, and then we're going to move on for the first country experience presentation. Just checking if... Has anyone from Togo joined online?
Can you see the Zoom from here?
No.
Hello, good morning.
Good morning. Eric, okay. Good morning, Eric. Was that you?
Okay.
Thank
Bonjour.
you. Bonjour. We'll hand over to you. Apologies, my French is non-existent, but we are eager to hear about your experience. Thank you, Eric. Over to you. Thank you. I'm just going to keep this.
Ok. Bonjour, mesdames et messieurs. Je suis docteur Eric Nyasunu-Akpa. Je suis responsable du suivi évaluation à la division de l'immunisation du Togo. Et j'ai l'honneur et le plaisir de partager avec vous l'expérience de notre pays sur la transition MCV. Notre pays a fait la transition en octobre 2024 et cela a été matérialisé par une note de service du secrétaire général du ministère de la Santé comme facteurs qui nous ont décidé, qui nous ont poussé à faire ce passage. Il y a l'hésitation des agents de santé à ouvrir un flacon de 10 doses pour 2 ou 3 enfants. Les avantages de l'utilisation du flacon de 10 doses qui ont été relevés à travers la revue documentaire, l'opportunité de la subvention de Gavi pour le switch et l'accord du gouvernement pour ce switch. Ce sont ces 4 facteurs-là qui nous ont décidé à faire ce passage. Et comme principaux acteurs qui ont contribué à ce passage, nous pouvons citer le ministère de la Santé, précisément. Le ministère de la Santé, à travers la division d'immunisation. Il y a aussi Gavi, à travers son appui technique et financier. Nous pouvons citer aussi la plateforme des organisations de la société civile pour la vaccination et l'immunisation au Togo, qui est dénommée Post-Vie Togo. Il faut dire que cette plateforme a beaucoup contribué à ce passage, premièrement en remontant au ministère de la Santé les plaintes des communautés ou des parents d'enfants concernant les reports récurrents de leurs rendez-vous vaccinaux pour cause du nombre d'enfants insuffisant pour ouvrir les flacons de 10 doses, afin que le ministre de la Santé puisse prendre la mesure de la chose. Et lorsque le changement a été annoncé, les organisations de la société civile sont allées vers les communautés pour les informer sur le changement à venir et le soulagement que cela pourrait leur apporter. Ainsi, il était question d'expliquer aux communautés le pourquoi du changement pour qu'elles n'aient pas d'autres idées derrière la tête, comme par exemple penser que c'est à cause de la mauvaise qualité du vaccin qu'on est en train de faire le switch, ou qu'ils ne pensent pas cela. Donc, il y a aussi nos partenaires habituels tels que l'OMS et UNICEF qui nous ont appuyés dans ce passage. Prochain diapo. Comme principale attente, c'est d'apprendre de l'expérience des autres pays sur la conduite du switch afin de mieux conduire le futur switch que nous avons dans notre pays, à savoir celui du pentavalent vers l'hexavalent. Et comme question que nous aimerions poser aux autres participants, c'est qu'avec le recul, quelle est l'étape, quelle est selon vous l'étape clé pour une réussite du switch? Slide. En ce qui concerne la phase pré-transition, les réussites que nous pouvons relever, il y a d'abord l'élaboration des documents de soumission et leur approbation par Gavi, la mise en place d'un comité de coordination de la transition, que ce soit au niveau central, au niveau régional et au niveau district, l'inventaire des flacons de 10 doses et leur suivi périodique de niveau de consommation. Et enfin, pouvons citer aussi le renforcement de la capacité de la chaîne du froid pour être sûr de pouvoir bien stocker tous les nouveaux vaccins à 5 doses que le pays va recevoir. Slide. Comme défi ou difficulté à cette phase, c'est le changement des activités à tous les niveaux, ce qui a un peu ralenti la mise en œuvre du switch. Euh, L'épuisement des doses de RR avant le démarrage du switch. Nous avons choisi au niveau du pays d'épuiser totalement les flacons de RR à 10 doses avant de commencer véritablement l'utilisation des 5 doses pour éviter qu'il y ait d'embrouiller les prestataires de santé. Et ce qui a fait qu'il y a certains districts qui avaient épuisé plus rapidement que d'autres, donc ont commencé un peu plus tôt l'utilisation du flacon de 5 doses avant les autres. Et il y a aussi l'insuffisance de communication autour du switch. Nous n'avons pas assez communiqué autour du switch, surtout envers les prestataires de santé. Tous les prestataires de santé n'étaient pas au courant de ce switch et aussi envers la communauté. Slide. Comme ce que nous pouvons améliorer pour le futur, c'est la communication sur le processus du switch et aussi améliorer la planification des activités pour éviter beaucoup de chevauchements d'activités et aussi améliorer le redéploiement intra-régional des flacons de 10 doses afin de faciliter une consommation optimale. Slide. En ce qui concerne la phase de transition des prestations de services, comme réussite, nous pouvons citer le briefing des membres des équipes cadres de région et de districts, ainsi que des agents fascinateurs des formations sanitaires. Citer aussi la distribution des flacons de 5 doses avec l'utilisation effective des supports de gestion de stock, les fiches de stock et l'outil ESCMT. Et aussi dire que nous avons fait des supervisions pour suivre la mise en œuvre du switch, que ce soit au niveau central, au niveau région et au niveau district. Slide. Comme défi à ce niveau, c'est la gestion des données dans le DHIS2, parce que le paramétrage ne prenait pas en compte les flacons de 5 doses au début, mais par la suite, cela a été corrigé. Et il y a aussi l'information sur le switch de 10 à 5 doses qui n'est pas allée à tous les prestataires de santé. Slides. Donc, au niveau des prestations de services, ce que nous pouvons améliorer pour le futur, c'est de prévoir peut-être une ligne budgétaire pour la communication afin d'avoir facilité l'adhésion au switch par les prestataires et la communauté. Et aussi le renforcement des capacités de stockage avec l'acquisition de nouveaux équipements de la chaîne du froid en prévision des introductions et des futurs switches à réaliser par le pays. Slides. Au niveau de la phase post-transition, comme récit, nous pouvons citer le suivi du déroulement de la transition à tous les niveaux, le partage d'expériences de la transition entre les acteurs régionaux. Il y a eu des réunions qui ont été organisées pour permettre aux acteurs de partager leur expérience sur le switch entre acteurs régionaux. Et aussi, on peut noter comme réussite la réduction du taux de perte en vaccin qui est passé de 19 à 11%. Slides. Comme opportunité future, ce que nous pouvons améliorer pour le futur en ce qui concerne la phase post-transition, c'est la réalisation d'un documentaire qui va décrire le processus de transition, la poursuite des supervisions afin d'atteindre les objectifs du switch et aussi prendre en compte les bonnes pratiques et les leçons apprises du switch RR pour mieux conduire les futurs switch, à savoir celui du main A. On va passer du main A au main 5CV bientôt dans notre pays d'ici la fin de l'année, et aussi le passage du pentavalent à l'hexavalent. Slides. Mesdames et messieurs, voici ce que le Togo avait à partager avec vous et nous nous remercions pour votre aimable attention.
Merci. Thank you so much, Dr. Eric. That was a fantastic overview of the process in Togo. Are there any questions for Dr. Eric? I've got one, but is there any? Thank you. Any questions for Dr. Eric from the floor or from our online participants? Salim, is there anyone in the chat? No questions online yet? Yes, Maggie.
Hello, Dr. Eric. Thank you very much for sharing more about Togo's experience with the MCV 5-dose switch beginning in October 2024. As we've been having conversations here in Cape Town with countries that are planning the switch, one of the big issues that keep coming up again and again is how to manage stock during the transition process. And so you mentioned that that was also a challenge which Togo experienced. And I wanted to ask for some clarification just so we can better understand and countries in this room who are planning the switch can start to think about how they might deal with this challenge. It was my understanding that you said Togo issued some notification for health workers to quickly use up all the 10-dose stock before transitioning, and that led to a challenge with health workers using up stock perhaps too quickly. At first, maybe I misunderstood, so if you could clarify. And then wondering what the impact of that was, whether there were some stockouts during the transition process, and what advice you have for countries to avoid potential stockouts during the transition and maintain sufficient stock while transitioning from 10-dose to 5-dose vials. Thank you.
Je peux répondre en même temps ou bien prendre d'autres questions?
Yes. Sorry, thank you, Dr. Eric. You can answer. We'll go question by question. So over to you. Thank you.
D'accord. Merci beaucoup. Merci à Madame pour sa question, pour ses préoccupations par rapport à la gestion des stocks. Donc, je disais que au Togo, nous avons décidé de ne pas faire circuler en même temps les et les flacons de 10 doses et les flacons de 5 doses. Donc, nous avons décidé d'épuiser totalement les flacons à 10 doses avant de commencer l'utilisation des flacons à 5 doses. Donc, et on faisait un suivi périodique au niveau des districts afin de s'assurer que le district a épuisé son stock de 10 doses avant de commencer les flacons de 5 doses. Et puisque après avoir fait l'inventaire, on a noté que certains districts avaient beaucoup plus de stock que d'autres. Et vu le temps qui était prévu pour pouvoir commencer le switch, et quand on a constaté que certains ne pouvaient pas épuiser les stocks de 10 doses avant la date du switch, a eu à faire des redéploiements entre districts, ou bien entre régions, pour que les districts puissent écouler rapidement les stocks de 10 doses avant de commencer les 5 doses. C'est ce qui a été fait. Donc, au final, on a eu des districts qui ont commencé un peu plus tôt l'utilisation des 5 doses avant d'autres. Donc, il fallait suivre tous ces mouvements-là au niveau des districts et des régions. C'est ce qui n'a pas été vraiment facile pour nous au niveau central. C'est ce que j'avais à partager, ce que j'avais à préciser. J'espère que j'ai répondu à votre question.
Thank you so much, Dr. Eric. Before we move on, my lead facilitator has just told me that I forgot to introduce myself, as we all have. So I'm Bronte, and I'm from the Vaccines for Africa UCT unit. And any other questions? Dr. Belch, I see you had your hand up.
Merci beaucoup, Dr. Eric. Bonjour, ici Balcha. Vous nous avez dit que ce sont juste des questions de clarification. Vous nous avez dit que le paramétrage DHIS2 n'inclut pas les 5 doses selon votre présentation juste maintenant. Est-ce que la situation a changé depuis ou vous n'incluez pas le monitorage de 5 doses dans le système de monitorage? Deuxièmement, en ce qui concerne le changement depuis l'adoption de flacons de 5 doses, est-ce que vous avez constaté aucun changement sur la fréquence de sessions de vaccination, aucun changement sur le taux de perte, soit la couverture de vaccination après l'introduction de 5 doses? Merci beaucoup.
Je n'avais pas bien entendu. Si vous pouvez répondre à la première question, ça me ferait plaisir.
Oui, la première question, je l'ai tirée de la présentation que vous venez de faire. Vous nous avez dit que le système DHIS2 n'inclut pas le monitorage des flacons de 5 doses. Peut-être le système a été désigné avant, pendant l'utilisation de flacons de 5 doses. Est-ce que maintenant le monitorage a changé pour assurer qu'on peut monitorer les flacons de 5 doses?
M. Bacha, Dr. Bacha, pour vos préoccupations. Et par rapport au DHIS2, comme je l'avais dit, c'est vrai, et quand on avait commencé le switch, les flacons de 5 doses n'étaient pas paramétrés dans le DHIS2, mais quelque temps après, ça a été fait. Donc actuellement, nous monitorons les flacons de 5 doses dans le DATS2. En ce qui concerne les effets du switch, oui, et on a noté que actuellement, on fait beaucoup plus de sessions de vaccination, puisque maintenant, on peut ouvrir les flacons de 5 doses, même avec deux enfants. Déjà, on peut les ouvrir. Donc, ce fait que le nombre de sessions de vaccination ont augmenté. Et le taux de perte, je l'avais dit, on a constaté que c'était passé de 19 à 11%. Mais au niveau des couvertures, on n'a pas encore constaté vraiment une évolution parce que les couvertures de 2025 et de 2024 sont pratiquement similaires. Merci.
Peut-être c'est très tôt pour parler du couverture comme vous venez de dire, mais au moins en ce qui concerne le nombre d'enfants qu'on peut atteindre pendant chaque session, est-ce que vous avez constaté aucun changement là-bas?
Oui, je n'ai pas de chiffres à vous donner précisément pour cela, mais ce qu'on a constaté entre l'année dernière, 2024 et 2025, où on a constaté quand même que par rapport à la vaccination, le nombre d'enfants vaccinés a quand même augmenté par rapport à l'année où on n'avait pas encore commencé le switch. Mais je n'ai pas de données précises à vous donner, malheureusement. Merci.
Merci.
Thank you. Any other questions from the floor? Thank you, Dr. Eric, for answering so comprehensively. We have 6 minutes left, and Dr. Eric, the question I have for you is you heavily emphasized communication for this switch. Was that communication to the healthcare workers or across your health service delivery level, so at your district or country level? Can you maybe elaborate on that for us, please?
Merci, docteur, pour la question. Oui, la communication, c'est essentiellement à deux niveaux. Au niveau des soignants d'abord, parce que la vaccination ne concerne pas seulement les agents vaccinateurs ou bien les responsables de formation sanitaire, ça concerne tout le monde. Donc, nous estimons que tous les prestataires de santé doivent être au courant des changements dans le programme de vaccination. Euh, Par exemple, quelquefois, on a eu ce souci au niveau, lorsqu'on faisait l'introduction du HPV, où on n'avait pas associé assez les ordres professionnels de santé, les associations professionnelles de santé, et ce qui fait que certains, lorsqu'on leur posait la question que, par exemple, est-ce que il paraît qu'il y a un nouveau vaccin qui est introduit dans le pays, est-ce que vous êtes au courant? Ils disent qu'ils ne sont pas au courant, alors que ce sont des acteurs du système de santé, et ce qui fait que les gens sont démotivés pour se faire vacciner. Donc, nous pensons que c'est vraiment important de communiquer aussi vers les prestataires de santé, même s'ils ne sont pas impliqués directement dans la vaccination, pour qu'ils soient au courant quand même des changements dans le programme, pour qu'ils puissent relayer ces informations dans la communauté. Et aussi, ne pas oublier aussi, la communauté aussi doit être, la communauté doit aller vers la communauté aussi, pour que cette communauté puisse accepter ces changements-là. Qu'elle ne pense pas que c'est parce que peut-être il y a l'ancien vaccin était de mauvaise qualité, c'est pourquoi on est en train de le changer, mais que c'est que pour les aider à pouvoir, pour améliorer leurs prestations et pouvoir améliorer les couvertures vaccinales en vue d'éviter les épidémies dans le futur. Donc, c'est pour cela que j'avais insisté sur la communication. Merci.
Fantastic. Merci, Dr. Eric. I see we have one hand online. So Mansama Kola, is that an old hand or is that a question you would like to ask? You can unmute and ask your question, please.
Ok, bonjour à tous. Est-ce que vous m'entendez?
Oui.
Yes. Oui. Yes, we can.
Ok, merci beaucoup. Je suis Augustin Kola, je suis le coordinateur de la plateforme Poursuivi Togo. Donc, je suis de l'équipe du Togo. Toutes nos excuses parce qu'on n'a pas eu à temps les visas pour arriver. Mais je voudrais juste rebondir sur la question de la communication. D'abord, il faut noter que le vaccin RR même est un défi national vu que c'est un vaccin qui va dans la deuxième année de vie. Parce que les communautés avant ne faisaient pas de la vaccination jusqu'à la deuxième année de vie. Et donc, quand vous allez regarder, vous allez voir que dans la deuxième année, on a un défi parce que les gens oublient toujours de revenir. Et donc, comme on veut changer aussi le switch, c'était aussi pour les permettre de bien, parce que quand les gens, ceux qui font l'effort pour arriver, comme il a expliqué, et qui n'arrivent pas à avoir accès au vaccin parce que le nombre d'enfants n'était pas beaucoup, ça n'allait pas, ça augmentait le nombre de périodes de vue des gens qui disparaissaient comme ça et puis qui ne revenaient plus. Et donc, avec les 5 doses, on n'a pas eu beaucoup de plaintes comme avec les 10 doses. C'est pour rebondir à la question, est-ce qu'on a senti, mais au niveau communautaire, on n'a pas aussi eu beaucoup de plaintes comme à l'époque quand on utilisait les vaccins de 10 doses. Et donc, la communication qu'on a dû faire, euh, c'est qu'il faut que les communautés comprennent parce que c'est très sensible quand on change un vaccin et qu'on ne dit rien. La plupart du temps, les gens pensent que ce vaccin-là, c'est parce que soit il a un souci, soit il n'était pas bon, c'est pour ça qu'on veut le changer. Donc, la communication aussi, au niveau communautaire, a été accentuée pour expliquer pourquoi on fait ce changement et quel est l'avantage que cela va donner. Et comme il a dit, les autres ordres professionnels, c'est important de les associer parce que de plus en plus, les communautés, pour prendre des décisions, se réfèrent à leurs soignants, parfois à leurs soignants, à leurs infirmiers, à leurs médecins. Et donc, quand ils ne sont pas au courant, eux, ils disent je ne suis pas au courant et puis c'est fini. Et ça bloque le processus de continuité de cette vaccination-là. Donc voilà ce que je voudrais ajouter à ce que Dr. Eric a dit. Je vous remercie. Merci beaucoup.
Thank you so much. I'm so happy that our online participants are awake and engaged. We're very happy to hear that. We thank you, Togo and Dr. Eric, for sharing your experiences, your valuable insight, echoing much of what we've heard from the last 2 days as well, and really emphasizing the need for good monitoring systems and communication, as you've highlighted this morning. So with that, I have 18 seconds left. And Dr. Eric, we thank you so much for your time, for joining us online. We really appreciate it. Thank you. Back to you, Kenilwe.
Good morning. How is everybody feeling? It's day 3. How is everybody feeling? Looking forward to going home? Okay. Well, we still have another couple of hours together. So, as Petronella mentioned earlier on, we're going to try and go through the remainder of the agenda as quickly as possible because we understand that people have been sitting for a very long time and would like to get an opportunity to get out of the conference room. So we're going to try our best, but with your help. So it won't happen without your support. But for now, moving on back to the agenda, I have the pleasure of introducing Dr. Balcha, who is going to present on the MCV review study results. So Dr. Balcha, over to you.
Good morning again, colleagues. So basically, I'm not going to tell you anything that you haven't heard so far, because this is a synthesis of findings from different countries that we managed to put together, I think, last year. But before I go ahead, I'd like to acknowledge the huge support that we've had from the Linksbridge colleagues, Reba, Maggie, Lauren, everybody who was involved in putting together this publication, but more importantly, in synthesizing the lessons from the 7 countries which I'm going to be presenting. So this has already been published. The link is available on the front page here if you have access to the PowerPoint, but you can just Google it and pick it up. So, going back to the background. At regional level, we have this goal that I talked about the day before yesterday to eliminate measles and rubella in at least 80% of the countries by 2030. And this cannot happen if we do not have a robust routine immunization program that can vaccinate children, that can reach ideally 95% coverage with both doses, so that we do not have to depend on mass vaccination campaigns, or rather we can build sustainable level of high population immunity. And as I gave you the example of Cameroon the other day, countries have been doing periodic campaigns. But in between these 3-yearly, 4-yearly campaigns, what happens in between there, what happens during that period is really, really critical. And that is what we mean by the day-to-day grind of routine immunization, being able to reach children, making sure that no child gets returned from a health facility because there are not enough kids to open a vial. And that brings us, of course, to the issue of the 5 dose. And not only 5 dose, but a number of other programmatic interventions that we can engage in to ensure that children are vaccinated as early as possible. And we've talked about this. I don't think I need to repeat, but as you all know, the measles vaccine, the measles rubella vaccine, is a lyophilized vaccine that needs to be reconstituted at the site of service delivery. And once reconstituted with its own diluent, we need to make sure that we get rid of it after 6 hours, whether we've used it all or not. So because of that, there is this huge concern that, oh, we're wasting doses. Oh, we don't have enough kids. So what do? We schedule measles vaccination, BCG vaccination, which suffers from the same situation. We schedule it once every week, once every 2 weeks, and in some places, once a month. The other day, I think the colleagues from UCT walked us through a journey map. So as the colleague was taking us through the journey map of this whole process, and we have had that discussion during one of the breaks as well, I was thinking of a journey that a mother takes from home, walking with a child on her back for somewhere around 5 kilometers, 6 kilometers or longer, coming to a health facility, made to wait for 4 hours, and told, oh, there aren't enough of you around, go back and come back next Wednesday. Will the mother come back? Mind you, she has a husband out in the farm who needs to be fed, whose clothes needs to be washed. She has other kids that she needs to tend to. Probably there's a pregnancy coming on the way. She has to cook. She has to do whatever she do. She has to go get water from the river. All of these things are daily burdens, daily realities for many women in the African context. And it is within such a context that we tell a mother, go back and come back next week. And the same may happen when she has her family planning appointments. She comes, the health worker is not there, he has gone to the field or any of a number of reasons and is told to come back next week. So definitely these are huge reasons for demotivation for parents to come back with their kids for vaccination. Or she may come to an outreach site and has never been informed that the outreach visit has been cancelled because there's no fuel, because the health worker has a meeting that he has to attend in the district. These are daily realities, basically. So one small approach, very small approach to make it easy for health workers to provide vaccines on time to parents who have presented. That's what the 5 dose is all about. And we know it changes behavior. We know it has a positive impact. The study that was done in Zambia in 2020 basically has shown us that it can reduce vaccine wastage, it can increase MCV1 coverage and MCV2 coverage. Not because there is health education given at the same time, not because there is intensive focus and money thrown into the program, but just changes attributable to the change in formulation. So we can get higher coverage and lower wastage. So it was based on this that we looked at the experiences of early adopters of the 5-dose. So these were the 7 countries that we looked at, countries that switched somewhere around 2019, but even more recently. So Togo was the last one, I think, which switched at the end of 2024, beginning of 2025. So the plan was to do a field study where we go to the country, talk to the EPI program manager, talk to the logistician, talk to health workers, to look at records in the health facility, look at logistics records, talk to mothers. That was the plan, but unfortunately we could only do that in 2 countries, Lesotho and Eswatini. So for the rest of the countries, we were obliged to limit it to telephone interviews, Teams and Zoom calls with EPI managers, who gave us really valuable information, but qualitative information, basically. So this is the screenshot from the web page where the study was basically published. And as I said, it is qualitative. It does not have any of the quantitative aspects that Zambia and Ethiopia reported on the day before yesterday. So what did we see? Nearly all of the countries told us that there is the expected greater flexibility in service delivery because it allows health workers to open vials with smaller number of kits. All countries told us that there is an increase in the frequency of sessions. We just heard from Togo this morning, who also confirmed that there is an increase in the number of vaccination sessions where measles vials are opened. Because in the past, we know that was not the situation. Countries reported various levels of increase in coverage. Again, these are not, we're not trying to sneak quantitative response here. These were reported increases in coverage, as we heard from Lesotho, Zimbabwe, DRC, and so on. Wastage was reduced, health workers were more confident, and there was no major challenge with the cold chain as far as the accommodating 5-dose vials were concerned. And most of this was because we just came out of the COVID pandemic, and in order to accommodate COVID vaccines, which came over a short period of time, there were intense efforts that countries made to expand their cold chain capacity with the support of Gavi, with the support of donors and partners. So because of that, there was literally no major challenges to the cold chain system. In terms of results, I think, so the studies in the level of rollout in Lesotho, Eswatini, and Equatorial Guinea was more informal. There was no guidance as such for how to do that switch in many countries. So the early adopters like Lesotho and Eswatini, they used their own experiences of switch with other vaccines to just informally roll it out. There was no training, there was no guidance, there was no big fanfare around it. Whereas for DRC, Niger, Togo, and Zimbabwe, there was a little bit of a process involved where it was announced, there was some communication, health workers were given note verbals or guidances which guides the level of rollout and so on and so forth. In 6 of the 7 countries, there was an attempt to do a thorough evaluation of the cold chain system at national and subnational level before they committed to the switch. As I said, it was not a major challenge because of the cold chain expansion work that was done, but at least there was a formal process followed to be able to switch. And again, some of these used tools that were developed with the support of Linksbridge, where there was some degree of modeling and scenario planning that was done. What will happen if we introduce 5 dose, if we switch from 10 dose to 5 dose at this point? Do we have enough cold chain to allow us to do that? Do we expect any major change in coverage? Do we expect a decline in wastage? Based on information that we feed into the tool, we can a little bit do that kind of scenario modeling. And I think the Cameroon EPI manager earlier, I think yesterday in his presentation, told us that they went through that tool just like many other countries did. What were some of the gaps that were noted and the challenges? Not many countries had NITAG involved in the process. I think in view of what we discussed about VPOP on Monday, there are a number of changes within the EPI program that are expected to come going forward. So for any country that wants to change in the future, we advise that they go through this process of trying to prioritize to see if indeed it is in the country's best interest to prioritize the switch to 5 dose vis-a-vis any other changes that may come around in their EPI program. So the NITAG's involvement is critical. Until recently, there was no standardized checklist to guide the process of the switch, which was a major gap. And so that, to a certain extent, led to countries improvising, I can say, in terms of how they handle this. And as happens, countries have policy documents, guidelines, training manuals, monitoring tools, and so on. So when we bring about a change in a vaccine formulation like this, or when we introduce a new vaccine, ideally you have to go through the whole process of accommodating the change within the policy document, within the guidelines, within the manuals, within the training documents and the tools. And there were some gaps noted in that process in some countries. Tracking of wastage, questions about data quality, and limitations in being able to monitor what has changed in terms of wastage, in terms of coverage. There hasn't been a structural process done in these early adopters to look at what has changed. So these are areas where we think significant improvements can be made going forward. And then in terms of enabling factors, I mentioned about the cold chain and the work that was done to expand the cold chain, which was very useful. As we heard from many countries, including Togo this morning, there were very deliberate attempts in many countries to make sure that 10 dose was depleted before districts and health facilities switched to 5 dose formulations. And of course, efforts were made in all countries to ensure that there was no period of stock out in between. Partners were there accompanying countries in all of these cases. There were some cascade training done using whatever little available guidance that was made available to countries, communication and trying to integrate with other EPI activities were all things that helped to a certain extent for countries to succeed. So going forward, what are the lessons learned and what do we recommend? There has to be a formal process and a plan and a well thought out approach to switching vaccine formulations. It cannot be done as an informal thing. We have seen that with MCV2, and I think I quoted some examples the other day where MCV2 introduction was done in some of the early adopters. Again, this is the same vaccine. There's no change in the vaccine. You just push it into the second year of life. No, it doesn't work like that. The same with the change in 5 dose. You have to make sure that health workers are aware. You have to make sure that your tools are managed. You have to make sure that your training and everything goes together. Would be good to ensure that there is some degree of data collection pre-switch and post-switch so that you measure the impact of this change so that we understand what is going right, what is going wrong. And then in terms of guiding countries better, I think there is a need for a standardized checklist. I think since then there has been a checklist that was developed and sent out to countries, but we need still to learn some lessons and make sure that we can give good guidance and planning and preparation tools. Investing in evidence generation, and I think what NISH did, what VACFA did in terms of supporting Zambia and Ethiopia for this quantitative analysis was part of a systematic effort to generate evidence. Finally, in conclusion, we know fewer dose vials, if used properly, if introduced properly, can help increase session frequency, reach unreached kids, minimize missed opportunities, increase coverage while minimizing wastage. But only if it's done with deliberate planning, with good partner coordination, engaging the NITAG and ICCs, and embedding the necessary processes so that we can monitor any changes going forward. So this is purely qualitative, and as I promised at the beginning, I haven't told you anything that you didn't know already, but just to formalize it and let you know that we have managed to get this information together from these 7 countries where we did that assessment. And I thank all the countries that contributed to this study and also my colleagues at Lexbridge. Thank you so much. Can be discussed. Yeah. Yeah. Oh.
Oh, what I was saying is that now we're going to set up a panel discussion, which then the questions from the presentation are also going to be integrated into the panel discussion. So we are trying to shorten the agenda. Okay? So we're going to quickly move the chairs and prepare the setup for the presentation. We can remove the extra. Oh, just, okay. All right, and this thing is not on. Oh. I was expecting Boucher's presentation to go on longer than it did. Yeah. All right, and so we're going to call on stage, because for the past 2 days, we've been doing everything in English. Most speakers have been speaking in English, but we also have participants that are French speakers in the room. So it's our turn to be the ones who are listening to the discussion amongst the French speakers. and get to learn more from both Togo and Cameroon. So I'm going to call to the stage the team from Cameroon and Togo, and Dr. Balcha, who's going to be facilitating the discussion. All the team, yes. Do we have a it's here. There you go.
I have just to talk like, okay. Une fois que tu as le micro, je vais plus bavarder. Je vais allumer. Hein? Je peux pas raconter les. C'est en ligne, sont en train d'écrire sur vous là. Yeah.
Bonjour collègues, est-ce que vous m'entendez, les collègues en ligne? Vous m'entendez? Ok, merci. Ok, bonjour collègues, ici Balcha, on va faire un petit échange en franglais aujourd'hui. Mais tout d'abord, je vais demander aux collègues ici de se présenter brièvement.
Oui. Bonjour, je suis Dr. Shalom. Je suis le directeur du PEVO du Cameroun.
Okay.
Can you speak on the mic? I have a mic. Vous m'entendez? Je peux. Là, vous m'entendez? Ok. Donc, ce que je vais faire, c'est de rapprocher jusqu'ici et parler dedans. Okay. C'est bon? Ok, merci. Non, mais je me suis déjà présenté. Il faut faire comme moi. Je pense qu'il faut ramener. Oui.
Okay, bonjour à tout le monde. Moi, c'est Dr. Clarence Banga. Je suis programme manager vaccines à Tchai au Cameroun et nous accompagnons le PEV dans ses priorités. Merci.
Okay, merci.
Bonjour à tout le monde. Je suis Dr. Efouba Gisèle. Je suis en charge des prestations de services de vaccination au programme élargi de vaccination.
Au Togo?
Cameroun.
Bonjour à tous. Je suis Dr. Sophie Idri. Je suis médecin-chef de district au Togo. Donc, je représente le ministère de la Santé de mon pays.
Merci beaucoup, collègues. Alors, ici, nous avons deux pays. Le Togo, qui a déjà fait le switch de 10 doses à 5 doses il y a plus d'un an. Et on vient d'entendre la présentation qui a été faite ce matin. Et nous avons le Cameroun qui est en train de planifier pour faire le changement avant fin cette année. Alors, pour commencer avec le Togo, avec l'expérience que vous avez eue dans ce processus, qu'est-ce que vous feriez différemment après l'expérience que vous avez eue? Est-ce qu'il y a quelque chose que vous feriez différemment? Peut-être quelques leçons que vous avez apprises pour améliorer s'il y a telle sorte d'occasion pour changement au hexavalent, par exemple.
Ok, donc merci Dr. Bacha pour la question. Pour ma part, je dirais que la leçon apprise que nous avions retenue se situe autour de la communication. La communication des personnels de santé et la communication à la population. Parce qu'avant le switch, comme l'a présenté Dr Eric, nous avions le personnel de santé avait des difficultés à ouvrir les flacons de 10 doses si les enfants n'étaient pas en grand nombre. Voilà. Donc, ce qui faisait que la population était assez réticente à venir dans les formations sanitaires, même lors des stratégies avancées, quand les acteurs allaient sur le terrain, ne trouvaient qu'un ou deux enfants, ils n'arrivaient pas à ouvrir les flacons. Donc, la population était réticente à revenir dans la formation sanitaire, sachant qu'ils ont d'autres activités à mener et autres. Et donc, nous pensons que pour que d'autres suites se fassent, il faut que l'on communique assez sur ce qui va s'implémenter pour qu'il y ait l'adhésion de tous les acteurs et aussi de la communauté.
Ok, merci beaucoup. Et en ce qui concerne la logistique de gestion de vaccins, la logistique de processus de monitorage, des outils pour monitorage et tout ça, est-ce qu'il y a quelque chose que vous avez appris, que vous pensez est une leçon très importante dans le processus?
Je ne sais pas si Dr Eric est en ligne. Il serait bien utile que cette question-là lui soit adressée. Je ne sais pas si il est en ligne. Voilà.
Dr Eric, vous êtes en ligne? Vous nous entendez?
Oui, Dr Bachar, je suis là.
Ok, merci beaucoup.
Oui, par rapport à votre question, par rapport à la logistique. D'accord. Par rapport à la logistique, oui, c'est une leçon aussi apprise au niveau du switch. On ne peut pas faire le switch sans s'assurer que on a une capacité de chaîne de froid suffisante pour pouvoir avoir ces nouveaux vaccins. Donc, pour l'hexavalent, le passage du penta à l'hexavalent qui va se faire dans notre pays, nous pensions même renforcer davantage exactement dans la chaîne de froid au niveau des formations sanitaires, au niveau des districts et des régions, pour que lorsque ce nouveau vaccin aussi va arriver, on n'ait pas de soucis en ce qui concerne le stockage des vaccins. Et aussi au niveau du monitorage il est prévu aussi que nous, comment on va le dire, on mette à jour voilà, les outils de gestion, que ce soit de suivi, évaluation ou bien de logistique, pour que nous puissions collecter toutes les données relatives au changement du vaccin, ne pas rester avec les anciennes dénominations, mais s'adapter, changer au fur et à mesure pour que les acteurs puissent bien collecter les données sur le terrain, pour qu'il n'y ait pas de discordance des données au final. C'est ce que j'ai pu ajouter. Merci.
Ok, merci beaucoup, Dr Eric. Et maintenant, pour juste avoir l'opinion des collègues de Cameroun, en ce qui concerne la logistique, est-ce que le travail a été fait déjà pour assurer que l'espace de chaîne de froid est adéquat au niveau pays, au niveau national, soit au niveau sous-national et opérationnel?
Ok, oui. Dans notre façon de faire, nous avons une planification pluriannuelle de tous les changements que nous prévoyons. Et on avait déjà prévu ce changement sur la période de 2024 à 2028, puisque c'est ça notre plan pluriannuel actuel. Et lorsque nous faisions l'analyse des gaps en espace de stockage, il y avait déjà ce paramètre, en plus de l'introduction du vaccin contre le paludisme et puis éventuellement l'introduction du vaccin pour l'hépatite B à la naissance. Et notre plan d'expansion des équipements de la chaîne de froid a tenu compte de tous ces changements-là et nous avons exactement les équipements qu'il faut pour couvrir au moins 82% des besoins actuellement au niveau des formations sanitaires. Tous les besoins sont satisfaits dans les dépôts centrales, les dépôts régionaux et les dépôts des districts. Mais pour les dépôts de formation sanitaire, on a encore 18% des gaps qui seront forcément comblés au cours des prochaines années.
Ok, merci beaucoup. Et sur le volet communication, peut-être la question pour les autres collègues du Cameroun, quel est le rôle prévu des ONG et des civil society organizations en ce qui concerne pour appuyer le processus de déroulement de cette dose?
Ok, merci, docteur. Oui, je crois que la communication, comme notre collègue du Togo l'a dit tout à l'heure, est un volet très important pour accompagner ce switch, n'est-ce pas? Et je crois que les ONG et surtout les OBC au niveau communautaire ont un rôle très important à jouer par rapport à ceci. Et la communication devrait se faire des deux côtés. Du premier côté, côté prestataire de santé, vraiment pousser cette communication et vraiment s'appuyer sur le fait que ce switch devrait en principe leur permettre de vacciner plus d'enfants sans nécessairement avoir peur de perdre plusieurs doses du vaccin et vraiment s'assurer que ce message-là passe et qu'ils le mettent en pratique. Et maintenant, il y aura l'autre côté qui est vraiment la communication envers la population, qui, avec tout ce qui se passait par rapport au Covid et la réticence qui existe actuellement vers la vaccination, vraiment leur faire comprendre que c'est un switch qui nous permettra d'aller dans la direction où ils n'auront pas revenu plusieurs fois à la formation sanitaire juste pour chercher un vaccin particulier. Et c'est un switch qui leur permettra d'avoir les enfants vaccinés un peu plus fréquemment, n'est-ce pas? Et je crois que c'est vraiment sur ce point-là que toutes les différentes parties prenantes et les acteurs ont un rôle à jouer. C'est vraiment faire passer ce message-là et faire comprendre aux deux parties impliquées l'avantage qu'amène le switch. Et c'est une fois que ce message est passé et accepté par ces différentes parties prenantes qu'on aura vraiment l'effet positif qu'on va avoir sur le plan du nombre d'enfants vaccinés et de couverture vaccinale.
Ok, merci beaucoup. Oui, allez-y.
Oui, je voulais ajouter que actuellement, ce que nous avons déjà mis en place avant le switch, c'est déjà de communiquer avec les prestataires sur le fait qu'il faut ouvrir les flacons. Donc même avec les flacons de 10 doses actuellement, nous sommes en train de sensibiliser à travers même des affiches qu'on a conçues, à travers des formations pour leur dire il n'est pas question de renvoyer une maman qui a fait des kilomètres pour se rendre dans une formation sanitaire parce qu'il n'y a pas assez de personnes pour ouvrir le flacon. Donc actuellement, déjà, on a réussi à ancrer dans leur mémoire qu'il faut pouvoir ouvrir un flacon même pour 2 personnes. Certes, à côté de ça, on a une planification qui est recommandée de regrouper les jours de vaccination des vaccins lyophilisés pour réduire les pertes. Mais le conseil qui est donné à côté, c'est que si jamais une maman arrive à la formation sanitaire et que ce n'était pas le jour du vaccin lyophilisé, vaut mieux la vacciner que la laisser partir, parce qu'en la laissant partir, c'est plusieurs mamans qu'on va perdre derrière. Donc, on est vraiment en train de travailler sur ça avant d'arriver à l'étape où on va switcher au vaccin de 5 doses.
Ok, excellent, merci beaucoup. Et puis, dans le même sens, peut-être l'implication des pédiatres, des médecins, des académiciens et tout ça. Est-ce que vous avez déjà impliqué ces genres de collègues? Peut-être on peut commencer avec Togo. Dans vos processus, est-ce que vous avez impliqué les associations des médecins, des pédiatres, des infirmières et tout ça? Parce que la plupart des efforts que nous mettons sur la communication aux prestataires, aux acteurs de santé, c'est sur les prestataires de services au niveau périphérique. Mais les pédiatres, les médecins, les académiciens, est-ce que vous leur avez impliqué dans vos pays?
Ok, merci. Oui, je dirais directement oui, parce que pour ce switch-là, il y a eu une coordination, comité de coordination qui a été mis en place. Et normalement, je devais même arriver avec le professeur Atakuma, qui est un pédiatre, enseignant, chercheur. Donc, c'est vrai qu'au niveau du pays, en tant que lead de la coordination des pédiatres du pays, il a pu vraiment impliquer les autres collègues pédiatres et les autres collègues enseignants-chercheurs dans ce dynamisme-là et dans ce processus du switch.
Alors, pour moi, je pense qu'il s'agit aussi de cultiver un champion pour l'élimination de la rougeole et de rubéole. S'il y a la possibilité d'impliquer des cliniciens de haut niveau au niveau pays, ce sont toujours des collègues qui sont liés au ministère de la Santé, dans un certain sens, ou au premier du pays. Et ce sont des collègues qui peuvent avancer l'agenda d'élimination de la rougeole, comme on a vu dans des autres pays. Et c'est bien que vous les avez impliqués déjà. Et pour le Cameroun, est-ce qu'il y a un plan pour faire
Dr. Balcha, excuse me, I'm sorry to interrupt. I saw that Dr. Eric online wanted to jump in. So, Dr. Eric, we saw your hand if you wanted to contribute from your perspective.
Merci beaucoup. Merci à Dr. Balcha pour avoir évoqué ce point qui est vraiment très important au niveau du Togo. Pour compléter ce que Dr. Edri a dit tout à l'heure, nous avons au Togo, depuis quelques années, entrepris d'associer davantage les associations de professionnels de santé à nos activités, surtout les campagnes de vaccination, mais les instructions de vaccins. Pour donner un exemple, par exemple, la dernière fois pour la campagne RR de 2025, nous avons associé les ordres des médecins du Togo, les ordres des pharmaciens, les pédiatres, les sages-femmes, même les infirmiers et des assistants médicaux de notre pays. Nous les avons regroupés pour les partager l'information sur la campagne pour que, à leur tour, ces professionnels de santé puissent partager l'information sur la campagne de vaccination RR que nous avons tenue en 2025 pour qu'on puisse avoir l'adhésion de tous les prestataires et relayer ces informations dans la communauté. Donc, depuis quelques années, c'est ce que nous envisageons de faire. Et pour les prochaines campagnes et les prochains switches à faire aussi, nous allons continuer à les associer, car nous avons trouvé que c'est vraiment important pour pouvoir partager l'information, non seulement dans le milieu professionnel de santé, mais aussi dans la communauté. Merci.
Ok, merci beaucoup, Dr. Eric, pour ces opinions. Et pour le Cameroun?
Oui, pour le... Ok. Pour le Cameroun, nous avons plusieurs cadres de concertation. Le premier, c'est vraiment le NITAC. Dans le NITAC, nous avons compris que c'était le milieu de discussion scientifique par excellence. Nous avons fait représenter les sociétés savantes dans le NITAC. Donc, quand on discutait justement sur la rougeole, c'était surtout une préoccupation de la Société camerounaise de pédiatrie, dont je suis membre moi-même d'ailleurs. Ce n'est pas que les pédiatres, c'est toute personne qui s'occupe des enfants. Donc, après le NITAG, où cette discussion a été faite, il y a d'autres cadres de concertation, notamment les webinaires que nous faisons avec les cliniciens, sur chaque changement qui s'opère dans la vaccination, à chaque nouvelle campagne. Et nous avons parmi eux des champions qui sont très écoutés par les mamans et qui font des petites vidéos avant chaque campagne avec chaque changement que nous diffusons sur nos plateformes digitales. Lorsqu'une maman va voir, on va dire quoi, un docteur Ngou Patrick ou bien un docteur Epo, je les cite parce que c'est des visages qui sont très bien connus au Cameroun. Quand elles parlent, les mamans ont tendance à bien les écouter parce qu'ils ne sont pas complètement liés au ministère de la Santé en tant que gouvernement. C'est des personnes parfois qui travaillent dans le privé et qui ont une meilleure crédibilité. Donc, ce cadre de concertation que nous avons avec la Société camerounaise de pédiatrie a été formalisé avec un MOU entre le PEV et la Société camerounaise de pédiatrie pour que tout le temps on soit dans des échanges, pas seulement en amont d'un changement, mais même pour des questions aussi simples comme la compétition que le vaccin RR avait le ROR. Beaucoup de pédiatres avaient encore ça dans leur cabinet parce que ça créait une nouvelle demande pour les oreillons au Cameroun qui était un problème épidémiologique un peu accentué par le potentiel risque des oreillons sur l'infertilité par exemple. Beaucoup de pédiatres avaient utilisé cet argument pour vendre, on va dire comme ça, le RR, ce qui faisait la compétition avec la deuxième dose de RR. Avec la Société camerounaise de pédiatrie, ils ont pris définitivement position pour demander aux pédiatres de ne pas créer une compétition entre le ROR et le RE. Je pense que ça marche plutôt bien. Donc, c'est juste un exemple comme ça, mais pour tout changement, en fait, nous avons ces cadres de concertation qui nous permettent d'inclure les pédiatres et toute personne qui s'occupe des enfants.
Ok, merci beaucoup, Dr. Charles. Alors, pour le NITAG, fréquemment, nous utilisons les membres de NITAG comme des conseillères techniques, non? C'est dans le terme de référence du NITAG. Mais en ce qui concerne le plaidoyer agressif, que nous voulons des champions peut-être, ce que nous avons fait dans quelques pays, c'est d'établir des comités nationaux de vérification d'élimination de la rougeole et rubéole. Et à travers ces comités, ils assistent les programmes à documenter le progrès vers l'élimination de la rougeole et rubéole, la documentation, l'analyse des données et tout ce qu'il faut faire, mais aussi utiliser ces données, utiliser leur expérience et leur contact avec vous pour faire le plaidoyer aux autorités nationales ou aux autres partenaires. Et il y a beaucoup d'expérience chez Nigeria même. Ce n'est pas un pays qui est prêt à l'élimination, mais le processus de documentation de progrès, on en a utilisé pour faire le plaidoyer avec les autorités. Et vous pouvez peut-être en penser. Il y a des termes de référence génériques que nous pouvons partager avec vous pour voir si, pour l'ensemble des stratégies pour l'élimination de la rougeole. Ce n'est pas juste pour le changement de 5 doses, mais aussi pour la mise en œuvre des campagnes de qualité à temps, la mobilisation des ressources pour la surveillance, le labo et tout ça.
Oui, en fait, vous faites bien de le mentionner parce que le comité existe depuis 2023. Okay. Et nous avons déjà élaboré le premier rapport de progrès qui était assez complet et qui est utilisé comme base justement pour les plaidoyers stratégiques, qui fait de la rougeole quelque chose de prioritaire, même dans les programmes scolaires, où nous travaillons avec le ministère de l'Éducation qui exige aussi que la vaccination contre la rougeole soit rattrapée avant l'admission en maternelle. Et donc, nous sommes dans le processus d'élaborer le rapport de progrès pour l'année 2025. C'est vrai qu'on était occupé depuis le début de l'année, parce qu'il faut faire aussi le rapport de progrès polio, le rapport annuel, le rapport de progrès pour rougeole devrait continuer. Et justement, on est à court de ressources pour le fonctionnement de ce comité que nous voulons maintenir quand même pour cette année. C'est un des domaines où nous sollicitons le support également pour que cette bonne pratique ne s'arrête pas à ce niveau.
Excellent, merci beaucoup. Alors, juste pour demander s'il y a des questions, des points que les autres participants de la réunion ici veulent mettre aux collègues ici. If anybody has any questions that you'd like to pose to the panelists over here. Entre-temps, je vais vous demander de penser s'il y a des besoins d'assistance technique, des besoins d'appui qu'il vous faut quand vous considérez le changement pour le Cameroun. Même pour le Togo, je connais que vous êtes en train de battre pour gérer une flambée de rougeole maintenant, après la campagne que vous avez faite l'année dernière. S'il n'y a aucun appui technique, aucun besoin, aucune question que vous voulez poser ici. Mais pour le moment, je vais demander aux autres collègues de poser des questions.
Bonjour. That's all I have. So, of course, my question is not specific for Togo. I think for all of us, maybe I would like to hear more from Dr. Balcha from you at the end, because you know, the issue of measles 5-dose switch, we know we have trade-offs between, you know, we have been saying wastage might be increased or decreased, because we have been seeing, you know, that finding from different setup, one. The other thing is, you know, from the presentation you had as well and the discussion we had earlier, the health workers are now not as hesitant as before to open vials. That's a good move. And then at the same time, I can see a trade-off again. Now we're shifting to the Gavi 6.0, which is the country will be responsible to manage their own budget. Country vaccine budget is coming. And then how we are going to, you know, align the issue of opening every vial for every child versus the cost implication. Because, you know, it's not, the time is a bit different this time. We have to be mindful as well to consider not to lose all the vaccine doses at the same time reaching all children. So we have to we have to have some sort of mechanism to monitor that, because, you know, I would reiterate the issue that the government will be responsible managing its budget, not the vaccine. So these two things has to be in some sort of middle ground. So I think what could be the idea we can take, and then, you know, to make it in optimum level of utilization of resource, provided that we are also addressing our children.
Peut-être je vais utiliser cette occasion pour demander aux participants du panel s'ils ont quelques opinions sur ça. La question était, quand on introduit un changement de flacon de 10 doses à 5 doses, et quand on demande aux prestataires de services d'ouvrir des flacons pour chaque enfant qui se présente, comment est-ce qu'on va gérer l'augmentation du coût du vaccin et le taux de perte qu'on aura, particulièrement dans la situation actuelle, là où l'appui financement des donateurs, y compris le Gavi, n'est pas suffisant avec la situation actuelle du monde maintenant. Est-ce que vous avez aucune opinion sur ça? Oui.
Bon, personnellement, je pense que, comme j'ai dit tout à l'heure, déjà même avec les flacons de 10 doses, nous on encourage déjà l'ouverture des flacons, parce que en réalité, une analyse des données qui va nous montrer qu'on a un taux élevé, un taux de perte élevé, mais une couverture vaccinale élevée est acceptable comparé à avoir un taux de perte qui est élevé et une faible couverture vaccinale. Parce qu'actuellement, nous avons beaucoup d'épidémies de rougeole. Donc, le meilleur risque serait d'avoir des taux de perte élevés avec une couverture vaccinale satisfaisante aussi. Au moins, ça va montrer qu'on ouvre des flacons pour protéger des enfants. Au lieu d'avoir des flacons qu'on va préserver et qui, souvent, chez nous, arrivent à péremption étant fermés. Donc, on réussit à avoir des taux de perte en flacons fermés qui sont encore plus énervants que si on les avait ouverts pour protéger quelques enfants. Donc, pour moi, c'est vraiment cette logique qu'il faut peut-être mettre devant. Certes, il y a le coût du vaccin qui est à côté, mais le fait qu'on va switcher, pour moi, ne va pas forcément empêcher qu'on donne des orientations au personnel de santé sur comment ça va se faire. On va switcher, mais on va garder quand même une certaine planification pour les séances de vaccination pour les vaccins lyophilisés. Parce que là, on ne parle pas que du RR. Au Cameroun, quand on met les vaccins lyophilisés, on va parler du BCG, du VAA. Donc, ce sont généralement des vaccins qui vont se donner le même jour pour pouvoir augmenter le nombre de personnes qui vont recevoir ces vaccins. Dans certaines formations sanitaires où la population n'est pas très élevée, ce sera des vaccinations qui vont se faire une fois par mois, au lieu de le faire tout le temps. Dans les formations sanitaires où il y a assez de fréquentation, là, ils peuvent le faire tout le temps parce qu'ils savent que c'est gérable. Donc, moi, c'est un peu ça que je veux dire, c'est que nous, on va quand même continuer de leur dire, OK, même avec ce flacon qui est plus petit, on va regrouper quand même les vaccinations pour réduire le taux de perte, mais on garde à l'esprit que pour un parent qui vient de loin, parce que c'est vraiment ce que nous on explique, pour un parent qui vient de loin, il vaut mieux ouvrir le flacon pour pouvoir le vacciner, parce que c'est à travers ce parent-là qu'on va avoir d'autres parents qui vont comprendre qu'il faut venir à la vaccination parce qu'on ne refoule plus les gens. Alors que si on refoule un seul parent, c'est peut-être 100 autres parents qu'on a refoulés parce que c'est lui qui va aller dire en communauté non, il ne faut pas partir parce qu'on va dire qu'il n'y a pas le vaccin. Donc c'est vraiment mieux d'avoir un taux de perte élevé avec une couverture élevée au lieu d'avoir un taux de perte bas et une couverture vaccinale qui est basse. Ouais.
Yeah, so I'll switch to English. I think just to, excuse me, add a little bit to what my colleague has mentioned, I think we also have to look at cost from another angle. Let me explain what I mean. So if we are a little bit too orientated towards, we want to vaccinate, but we also want to make sure we don't limit wastage because it's a lot of investment, financial investment that's made to buy vaccines. But then we could also look at it from the angle where, opening those vials and probably wasting 1 or 2 doses to make sure children are vaccinated, to make sure we have better coverage, limits the risk of future recurrent outbreaks, right? And those outbreaks, they also use money. So I think it's more than just the investment made in buying the vaccines. It's also thinking about the ripple effects that maybe better coverage could have in terms of reduced outbreaks, in terms of reduced need for recurrent outbreak responses and campaigns and all that. So I think we're really at a point where probably we need to define, individual countries will need to define what success looks like to them, right? What is success to us? Is it making sure that we have the coverage we need to protect the general population and limit the amount of money we have to keep using to do recurrent outbreak responses and all that? So do we want to prioritize coverage over maybe spending a little bit more to buy the vaccine? Or is it the reverse? So I think that's a question that every country will have to answer, depending on the realities of the country. Yeah, but I also think we should not limit our vision in terms of cost to just what we spend on the vaccine, but also what we could spend in terms of outbreak responses because we're not getting the coverage we need to get.
And I have actual figures, dollar figures that I'm going to be sharing with Ethiopia right now on exactly what you said. But first, let's go to, si vous avez quelque chose à ajouter.
Oui, mais je suis d'avis avec mes collègues du Cameroun. L'objectif, c'est que l'on élimine la rougeole. Et donc, pouvoir juguler à la fois la réduction des taux de perte et la hausse des couvertures vaccinales, ce sera assez stratégique sur le terrain à cause sûrement par l'organisation, la planification des vaccinations en routine dans les formations sanitaires. Mais tel qu'elle a dit, c'est aussi de prioriser ces femmes-là qui viennent de loin.
Exactement.
Et surtout lors des stratégies avancées quand les acteurs de la santé vont vers les populations. Avoir en tête que l'objectif, c'est l'élimination de la rougeole et donc de vacciner les enfants contre, même si on devrait perdre des doses. Et déjà que le switch a été fait, je sais que ça aura un impact sur la réduction des pertes des doses. Voilà.
OK. Merci beaucoup. Et je vais revenir pour vous permettre de dire des derniers mots. Mais avant ça, just to come back to the question for Ethiopia. So actually, I'm now citing data that is published data on the economic cost of measles outbreaks in the Ethiopian context. I can share with you the link if you want, Kululat. So I think it was around 2016, we looked at the economic burden of measles outbreaks during the context of an outbreak in southern Ethiopia. And what we did was we looked at the health system costs as well as the individual costs for the patient and family in terms of case management, medicine, travel, lost time from work, and so on, but also the cost from the health service side incurred for investigating the outbreak and managing the outbreak. So per child affected during the outbreak, the cost of a measles outbreak was $74 US, overall health system cost. To prevent a measles disease, it costs less than $1, as you well know. So we are weighing $1 of prevention cost, or even a few dollars of wastage to reach that one child, versus that 74 US per child affected with measles. So if you can compare this, I think the response is, like my colleague said, it's very clear. The other point is, even for the families, so the family aspect, this is a very poor rural community. The health service delivery is very basic. So even for a child who has gotten measles, he gets admitted probably for 2 days in a small health center. He gets supportive treatment and probably antibiotics, vitamin A, whatever, not much. But there is also time spent away from the farm or from the small commercial activity that the family does. And that and all other family costs related, it amounts to somewhere around 2 to 3 months of income for the family, just when one child gets sick with measles. Again, this is a very poor rural family with less than the poverty line, but even then, 2 to 3 months of income is basically washed off while taking care of one child who gets measles. So when you look at it in this perspective, and policymakers need to have access to this kind of information. That is what helps make the decision. Yes, we should not be wasting doses, and we should use all programmatic options to make sure that we optimize the opportunities for vaccination. So the colleagues from Cameroon and Togo have clearly pointed out that it's not only a matter of changing that 5 dose, but programming your sessions very well, making sure that you minimize any missed opportunities, that you vaccinate not only 2 cohorts of children for MCV1 and MCV2, but any child above 2, up to 5, who may not have received any single measles dose, you can use that measles dose. It may not be added to your coverage, but it is a dose given to protect the child. Okay? So different options that can be done, but at the end of the day, the scale weighs on the other side, where you make all effort to protect the child as opposed to saving a dose from being wasted. Yeah. Kendall, I saw your hand up.
Thanks, that's really interesting data. Just one question about the input cost, the prevention cost. Is that just the cost of the vaccine, or is that across the entire health system cost?
Across the entire. So the investigation that was done, outbreak investigation, outbreak response that was done, and the planning and the time spent for outbreak response, the health workers who have to go extra length to provide vaccines within the outbreak community. Yes, please.
Good morning, Dr. Balcha, again. The panelists. Okay, I just wanted to ask a question that, is not directly related to what is being discussed, but it's something that I had picked up, and it's a little bit concerning to me. In rolling out the 5 dose, one of the issues that kept cropping up is the abundance of 10 dose vials or 10 doses. I just wanted to ask on the regional level, has there been any attempt or policy about sharing the doses? For example, Nigeria talks about maybe 10 million doses, and then we're surrounded by countries like Niger, Chad, that those doses might be useful for. Is there anything official that speaks to that or speaks against it?
Thank you so much. So there is nothing as such by way of guidance from WHO about you have to do this if you come up with excess doses like in the case of Nigeria. So there's nothing official there. But we work through UNICEF, which mainly handles the logistics, to try and see if there is any need for the use of some vaccines across borders.
Yes.
And that Nigeria may be willing to give, but we have to make sure that Niger is willing to receive at the same time.
Mm-hmm.
And of course, you may be able to share vaccines in national stocks, which you know about when they arrived, how they were conserved, and have a history of how the vaccine safety has been maintained. But once vaccine has been distributed from regional stocks to provincial and district level, we do not encourage by any means for those stocks to be collected and shared across borders. But those that are in national stocks, there have been instances in the past where they were shared with good success. But currently, I know UNICEF has strong reservations based on whatever history they have had in the past, strong reservations about that kind of those shares. And I think that may have emanated from since COVID time, when COVID vaccines that were shared across borders, I can say that were imposed on other countries. I'm sorry for lack of a better word. That were imposed on other countries, literally sat in the store and expired. And we know of many examples there where people were not comfortable to use that. So now UNICEF is not very aggressive in doing that. We tried that with the Nigerian dose, with the DRC dose, they were not very keen on pursuing.
Okay. Just, and that is, now that we are planning, we want as many countries as possible to switch. And from the few countries that have switched, this is a recurrent problem. Now, when other countries undertakes the switch, what is the plan to deal with excess doses on a regional basis that will be acceptable to the countries?
I think from my end, the only lesson that we can take from this experience that we shared is countries should forecast and plan for as much as possible in order to avoid being surprised by millions of doses suddenly being discovered. That, as I said yesterday, the Nigeria example, is something not to do, to how to avoid getting into that situation. But I'll repeat it again. If any country can manage this kind of situation, Nigeria can, because of the extensive, big country to begin with, but also extensive network of health workers, logisticians, cold chain system, which has matured significantly over the course of the last 2 decades, and they are managing it. And I think we are comfortable in the advice that is given for them to use MR for first dose, MCV for second dose. In any other country, I would significantly hesitate to give that kind of advice. And we have had countries where we say, no, you just use up your measles before going to MR. The same with 5 doses.
Okay. Okay,
I see that we're over time, and I definitely don't want to go over. But juste pour demander aux panélistes s'il y a des derniers mots qu'ils veulent partager. Quelques demandes, besoins d'assistance technique, de guidance, quel que ce soit que vous voulez partager avec les partenaires, les collègues qui sont en ligne ou avec les pays. On peut commencer avec Cameroun.
Merci. Moi, je crois que depuis le premier jour jusqu'à maintenant, je crois que ce que vous avez mentionné tout à l'heure, c'est vraiment le résumé le takeaway, je peux dire comme ça, ce qu'on doit rentrer avec, c'est vraiment cette planification vraiment détaillée sur le plan logistique pour qu'on ne se retrouve pas avec la situation de devoir gérer plusieurs doses des 2 différentes formulations, aussi bien les 10 doses que les 5 doses. Parce que ce que je capte en fait, dans la plupart des pays qui ont déjà fait ce switch, c'est le challenge majeur. Et avec des systèmes logistiques pas encore très matures, ça devient compliqué vraiment de savoir où est-ce qu'on a les 10 doses, où est-ce qu'on a les 5 doses, combien, et ainsi de suite. Donc je crois que c'est vraiment l'aspect majeur, n'est-ce pas, derrière ce switch, c'est vraiment avoir cette planification sur le plan logistique vraiment bien détaillée, bien fait. Et je crois vraiment que c'est dans cette optique-là qu'on va aussi essayer d'accompagner le PEV dans le travail qu'il va faire pour ce switch. Et un dernier aussi, c'est juste pour dire, vraiment, les pays devraient aussi trouver vraiment des méthodes plutôt, je ne sais pas si je vais dire innovantes, mais des astuces en fait pour pouvoir leur permettre de se retrouver dans une situation où une bonne partie des 10 doses qu'ils ont avant le switch est utilisée pour qu'il y ait vraiment un nombre de doses résiduelles très réduites après le switch. Donc c'est vraiment chercher des astuces et des différentes méthodes, des approches pour pouvoir prévenir cela. Donc pour moi, le takeaway majeur, c'est vraiment cette planification logistique qui doit se faire.
Merci beaucoup. Docteur.
Ok, en fait, des différents échanges qu'il y a eu depuis le début nous réconfortent un peu dans ce que nous avons planifié. Parce qu'effectivement, ayant entendu les difficultés que certains ont eues, nous sommes plus rassurés que le plan qu'on a prévu peut être celui qui va nous aider à éviter certaines choses. Parce qu'effectivement, on a pensé déjà que dans notre forecast, on va arrêter assez tôt la commande des vaccins de 10 doses pour qu'on commence déjà à nous donner les 5 doses. Et puis, on va utiliser l'opportunité de la campagne pour commencer à utiliser les 10 doses, écouler le stock même de la campagne avant et entrer un peu en rupture pour commencer à utiliser le stock de 5 doses. Donc, tous les échanges qu'il y a eu ici nous reconfortent vraiment que peut-être on est sur la bonne voie, mais on va quand même rester vigilant pour ne pas se retrouver dans les mêmes difficultés que nos confrères. Merci.
Merci, docteur.
Ok. Pour notre part, le switch a été déjà fait, donc maintenant c'est les perspectives de l'avenir, le switch du Penta à l'ESA. Donc voilà, nous retenons les leçons apprises de ce switch-là et pour que éventuellement pour la mise en œuvre, même avant, pendant et après, nous puissions pouvoir réussir le switch du Penta à l'ESA.
Okay.
Mais je ne sais pas si Dr Nyasunu est en ligne. Il pourra toujours intervenir.
Docteur Eric, vous êtes en ligne? S'il y a quelque chose que vous voulez ajouter?
Oui, à ce que Dr Edry vient d'ajouter, je pense que avec tout ce qu'on a appris tout au long de ces 3 jours, ça va nous aider à pouvoir mieux planifier les prochains switches à venir. Et dans le cas du switch RR qui est déjà fait, peut-être que l'assistance technique dont nous aurons besoin peut-être de l'OMS ou bien de l'UNICEF, c'est de voir planifier une étude d'impact du switch dans la communauté et nous soyons peut-être une étude comme ça que peut-être que l'OMS pourrait nous aider à mettre en place, à réaliser peut-être cette année ou bien l'année prochaine pour qu'on puisse voir l'impact du switch vraiment dans notre pays. C'est ce que j'aimerais ajouter. Merci.
Ok, merci beaucoup, Dr. Eric. Merci à tous les panélistes. Dr. Shalom a dû partir pour assister dans la réunion, mais je voudrais remercier tous. Je n'ai pas pensé que ma français va durer jusqu'à... mais on a survécu. Merci beaucoup and back to the coordinator. Thank you so much.
Thank you.
Thank you very much to Dr. Boucher and the panelists. So we have about 5 minutes remaining or just a little bit more than 5 minutes before coffee break. What I would like to request is, I did ask yesterday that countries think about a challenge that they would like to get ideas from the room for. So when we come back from the break, we're going to need that challenge. So hopefully you have identified one challenge that you would like collective brainstorming on, so that when you leave here, you have some ideas that you can take forward to explore how to solve that challenge in your own context. So that's what we're going to be doing next when we come back from the break. Have you thought about the challenge? Have you identified a challenge already? No? Okay. Let's take a moment to do that for the next couple of minutes. And then we're going to take a coffee break for about 10 minutes, as we have agreed at the beginning of at the start of the day. We're going to shorten the breaks because people would like to spend a little bit of time outside of the conference room before they go back home. Okay. Does everybody have access to the mural? I did share the link on the Zoom chat. So, yes, I can share it again. So take a moment to look at all the challenges that you have been noting down, and identify the one challenge that you would like to get, the most pressing one that you would like to get ideas on. There we go. The link is on the chat. So if you have colleagues online, maybe connect with them quickly and identify one challenge that you would like to get ideas on from the collective wisdom that we have in the room, because we're going to need that challenge when we come back from the break. And if you have your colleagues sitting next to you, you can have a discussion about the challenge. So one challenge that you would like to explore and get ideas on, and then we're going to try and get ideas from the rest of the room. You can also write it down on a piece of paper, and then we'll ask somebody to type it on the mural for you if you can't type it on the mural. Okay, we have about 2 minutes remaining before we take a break. Mumbi, do you have a challenge? Do you have a challenge? No, but you need one. You need to prioritize. Remember, for the past couple of days, you've been hearing about prioritization. You can no. It's impossible to tackle a million priorities. Okay, you've agreed on one. Fantastic. Okay, the one that the group agreed on. Okay, fantastic. Do you have a challenge? Have you identified a challenge for Togo?
Not yet.
Okay, then you're going to have to do it now during the coffee break because we need it from coffee break. Okay? All right, everyone, we're taking a 10-minute coffee break. 10-minute coffee break. I don't know. All I know is that we're sprinting through that.
Yeah, I'm gonna grab him to help with it, and I gotta remove the mics. I'm gonna send you the forms, the jot forms and whatnot. So I have it on a image that I'm gonna project for the QR codes, and then also gonna send the links in the Zoom and send it to their emails.
Okay, thank you.
What am I supposed to?
Can I take it or you want to hold it?
I can hold it here. Thank you. Okay, we're waiting for other people to come back. Hi, Susanna. How are you? We might have to move your session a little bit to just before lunch because everything is shifting because people want to finish early. So, yeah. Okay. Perfect. All right, we're just waiting for everybody to come back. Elizabeth is torturing people's ears with a gong. Sorry? Okay. Is everybody back? I see some tables are still empty. Okay. So we need to continue if we are to achieve our goal of finishing early. But like I said, we depend on each other on making this possible. So if people are not back, then that we're going to stay longer in the room. So as I've mentioned before break, we would like you to identify a challenge that you would like to get ideas for from the people in the room. And have you managed to identify your challenge? So we're going to hear from each country just telling us what the challenge is, and then we're going to move into the brainstorming aspect. So first, just identifying the challenge. Tell us what the challenge is for your country that you would like to get ideas for. And then we will move on to the ideation. We've been studying a lot on this side. Now we're going to start with Togo. Do you have your challenge ready? Not yet? Not yet? Okay. Nigeria, do you have your challenge ready? Yeah. Okay, do you want to quickly share it?
Okay, yeah, thank you very much, moderators. I think yesterday when we presented, we talked about after the campaign, we discovered that we have large number of MCV 10 in stock. So we have to kind of quickly come up with an interim guide on after brainstorming with our partners. We agree that we are going to use MR for first dose and MCV for second dose. And having done that, before the switch, we tried to, our data team already we kind of revised the prepared data tools, the tally sheet, the summary, and what have you. And what we have there is MR. We have changed from the measures alone to MR, from the all data tools, including the card. So now we are now in this situation. As we said, health workers, sometimes when they have that kind of challenge, that might lead to losing of data, because after giving the MR, okay, they record that there, but they give the MCV for second dose, start looking at where is MCV in this tally sheet. Because of the way they works, they might kind of say, we don't have a place to record the MCV for second dose, and that might lead to lots of data. Though we are working on how we can, as I've said, to have more engagement than the level. Then also communication of this also to the health workers. As I've said, we have interim guide we develop, and there are comments that it looks somehow complicated. So how are we going to address it to ensure that the message will be well passed to the health workers and also the caregivers for a kind of acceptance? Because when you are telling people you are giving, you say you are switching, you have done the switch. The initial training was you are going to use MR for 1 and 2. Now you are now coming with another. Another scenario. Somebody want to know why are you doing that and what's the benefit. So these are the.
So what is the one challenge that you would like to focus on out of the ones that you just mentioned?
Okay.
Which one are you wondering?
I think I will focus on this communication to.
Okay.
How to
Okay. Can we please type it on the mural so that it's visible to everybody? Ethiopia. Thank you for sharing the challenges. And it's going to be interesting to see if it comes up anywhere else, or whether there's any other country that has chosen the same. Please go ahead.
Thank you so much. So we have identified a lot of challenges, but just to put one only here. So we mentioned, so Ethiopia, we have a lots of service delivery points, like more than 60,000 health posts, health centers, and etc. So the issue we mentioned was like, we don't have still a good ELMIS that puts stock data visibility at the lower level, so that will continue to be a challenge to monitor the stock and then ensure that optimal utilization of vaccines, be it remaining 10 doses, 5 doses, and etc. So this is a challenge that we just put, because for the campaigns, for the coming time, plus for certain outbreak response immunization activities, definitely we will use 10 doses. And then for the routine, we are going to use 5 doses. So to monitor the stock, especially at the lower level, might be a challenge to continue.
Is it on the neural? Do you type it or?
Once you approved it, I'm just. All right, I'll put it there.
On neural number 19, if you can type it on the first sticky note. Okay. Do we have Malawi in the room? Reva, are you Malawi? Okay, let's move on to Zambia. What is your challenge?
I think our challenge is the issue of still the low MCV2 coverage and that high dropout rate. So trying to see around that. But then we also had a thought that we thought we could share with the team on the issue. I think even day one we talked about it, having access to documents on one place. So if we could have maybe access to other evaluations done by other countries, so that maybe we could check on some of these challenges and see whether we could use part of what they have used for us to be able to utilize for our specific challenges. Thank you.
Great. So out of those two things that you've mentioned, which one are we focusing on?
The other wasn't really a challenge, but just trying to see that idea and thought. The challenge is the low MCV2 coverage.
All right. Can you type it on mural 19 on the first sticky note? Great. You should only have the one sticky note with the challenge, Nigeria. You should have only the one sticky note with the challenge, and then you're going to get ideas from the group to answer your challenge. And then you're going to be answering other people's challenges. Does that make sense? Great. All right, Cameroon, do we have your challenge ready? So I'm just going to change the color of the challenge on all the murals so that when people are entering can see it. Please go ahead. Do you want me to project it? Okay, just give me a sec. There we go.
Yeah, I think we had this discussion just before the coffee break. But I think the main challenge that we are anticipating, because we've not yet done the switch, is really around, having both versions of the if I could call it that way, both versions of the vaccine in country. Yeah, the 5 and 10 doses. That's the biggest challenge we're anticipating. And I think across the presentation from the EPI manager yesterday and the discussions we had today, I guess everybody has seen how concerned we are about that challenge and how our planning has really been centered around making sure that we minimize that as much as possible. So that's really the main, I'd say the key thing in terms of challenge that we're anticipating. And so a lot of our planning is just around trying to mitigate that as much as possible. Yeah.
Okay, great. So hopefully you're going to get some great ideas from everybody in the room regarding that challenge. All right, let's hear from Togo.
Ok, merci. Bon, pour le Togo, je dirais que notre principal challenge, c'est d'améliorer la couverture vaccinale en RR2. RR2, surtout, l'améliorer, c'est principalement ce que je peux dire.
Okay, great. Right. So, every country has shared their challenge. And so what we're going to be doing next is that everybody is going to go into the mural number 19 of every country where there is a challenge and think of an idea to solve the challenge that is on the mural. So it's your gift to the country, an idea of how they might approach the challenge that they have identified. Does that make sense? All right. So we start now. So Nigeria, you're not working on your own mural, you're going to the other country's mural to add ideas, to read the challenge, and then adding an idea, leaving an idea, and then other people are going to come to your mural to leave an idea. So you're not coming up with an idea to your own challenge, but you're leaving an idea on others' mural, and then they'll come and leave an idea on your mural. Does that make sense?
Yeah.
And it's important to make sure that everybody gets an opportunity to leave an idea. Okay? So everybody gets an opportunity to leave an idea on the mural. Okay? So I'm going to give us about 10 minutes to think of ideas. Let's think of ideas for the challenges that have been identified by different countries. And we are doing all of this on the mural number 19. My colleagues from VACFA, are you on mural? Okay. Yeah. We said collective wisdom. If you have ideas on the challenges, by all means, everybody is contributing, trying to solve African problems. Yes. Yes, the idea on the mural, yeah. For a different country, not your own, yes. So you're reading their challenge, and then you're leaving an idea. Yes, that they have left. Yeah. You can type on the laptop if you want to. Yes. Call me and then you figure it out. Yeah, copy it and put it on
Please
Google.
put it either under it so that we English speakers
Can see, yeah. Yes, on top, next to the.
in the same sticky box. No,
Next to.
under.
No, next to the.
Somebody else had already
No, you can put it, yeah. We're trying to understand this.
So that's just improved coverage for MCV2.
Yeah, so.
That's what that means. So I just write it there. Okay.
Yeah. Maybe put it here.
Oh, underneath it?
Yeah.
Oh, on top. I get
yeah.
it.
And then you put an.
Underneath will be better. So that's,
Yeah. Yeah. And then you add another sticky note there so that whoever comes finds what. Just double click. No, you just double click. There you go. Or you can use the outline on the side. Yeah, so next time if you want to go to another country, just click on the outline and then it's going to bring up the list of countries and then you click on the one that you want to go to. Yeah. Huh? Yeah. You can do all the countries. We're doing all the countries. So we are doing all the countries. Where's the... Are there any people online? No, but that's us. No, you should be able to type on the sticky note. Yeah. So the page is locked so that it doesn't move. Yeah, just lock the page. But the sticky note should be. Go to.
The outline?
Yeah, and then find Nigeria.
Okay, that's just the best way to do it.
Yeah.
Okay, can you do that then? Yeah, got it. Okay.
Yeah.
So that's why I can see the lock on the big screen.
Yes. Yeah. Okay, you should be halfway through the countries by now. Because you're only starting it now. Oh, wow. Okay, I don't know the intricacies of a PC. Yes. You just need to focus on that. Just read that and then come up with and leave an idea in response to that. So don't worry about the ones that you cannot read. The people will be able to read them. Okay, I can see ideas are flowing, which is fantastic. All right, are the ideas flowing? Where are your ideas? Oh, you guys are doing collective brainstorming. Okay. Are you guys done? You've gone to all the countries and left ideas? Yes. Okay. Okay. And do you have more ideas for the countries that you've already visited? And you're adding them? Okay. Zambia, are you guys done? Have you gone to all the countries that have put a challenge on their mural? Still adding? Okay. Good to hear. Good to hear. All right. Cameroon, are you guys done? You've gone to all the countries and left ideas. Yes, some countries don't have challenges. Okay. Togo, are you done? Yes. You've gone to all the countries and left an idea. You did it. Okay. Okay. All right. So, just waiting for Zambia to finish, and then we're going to move on to the next. Yeah, that's what they said. Ethiopia, are you guys done? Are you guys done? Okay. You've gone to all the countries. Okay. All right. So we're giving Zambia a few seconds to finish. And then we're going to start sharing the ideas. We got a suggestion that it will be great to hear the ideas that were proposed to address the challenge. And maybe we'll start with Ethiopia this time. So you will take us through the challenge that you have and the ideas that you got to address the challenge. Let's go.
So to see the solutions that have been proposed.
Yeah. So what was the challenge and what are the solutions that were proposed?
Yeah. So the challenge we mentioned was the stock data visibility, especially at service delivery point. So few solutions have been proposed from maybe 3 countries. So digitalization was mentioned as, even it was mentioned specific tools which have been piloted in Ethiopia, like LMIs in the DHIS2 as well was suggested, and also to improve ELMIs in general, and consider incorporating AI tools also suggested. So these are some of the things mentioned. Of course, these are some of the initiatives. Some of them are ongoing initiatives that we are looking for. I think these are in line with our
with your thinking.
Exactly.
Okay.
Yeah.
Okay. And out of these that you've just read now, which ones resonate the most for your context? Which ones do you feel, okay, this one we will definitely, it will add value, and in terms of implementation, we would be able to implement?
The ELMIS, I think the third one, will be something which will be more feasible. And I think we have to think about the AI tools as well. But the ELMIS is something that we are working, and then I think that's very, very, ELMIS means advancing the ELMIS down to the service delivery point. So we have something started, and then definitely that will be more applicable for us.
And do you see it as some kind of a quick win in terms, if you were to evaluate these ideas, do you see it as a quick win, or do you see it as a more strategic, meaning that it has high value but some level of complexity in terms of implementation, or it's high value but it's got low complexity, meaning that it's something that you can do?
It is high value, but it's a strategic because it will take time and investment.
I see.
So yeah, we can rate it that way.
Okay.
Yes.
Okay. Great. So then what you can do is you can copy the sticky note and put it on where you think it fits in within the framework in Mural 20. Okay?
Okay.
All right. So, yes.
Yeah, so I'm sorry I didn't put my my ideas there, but it's rather a question to a certain extent. Does the national level need visibility on stock at the operational level? That's a question. I mean, this is a big country with multiple layers, administrative layers of managing these things. So there's the national level, there's the provincial level, there are the EPSS hubs, there are the zones and the waradas and the health facilities. So I think your question was the national level does not have visibility on stock levels at
service point.
At the service point.
Yeah.
But do we need that to begin with? I mean, the national level has bigger fish to fry, bigger things to manage.
Yeah.
So can't we leave that level of management and visibility to the zones and to the waradas, while the national level focuses on big things? That's one. The second point is, probably this is more a comment and not a question, it all depends on whether we have, and this may hold true for other countries, whether we have a push or a pull system of vaccine distribution. If it's a push system, before the operational level is ready, you are imposing some vaccines on them, and there may be 10 dose and 5 dose sitting at the same point, or overstock at some point, or even a gap if you don't push it on time. But if it's a pull kind of
logistic distribution system, when the health facility reaches what you mentioned the other day, the minimum stock point, it will trigger an order and they will come and collect the vaccine just so that they don't cause overstock or there's no gap. So what kind of system is working in the Ethiopian context? And I think if it's a pull system, it would work much better than a push system.
Great. Thank you, Dr. Balcha. So you're right, it's a pull system in Ethiopia, so the health facilities and or whereas will request based on a standard requesting for. So the thing that we were, so of course at national, and so when I'm saying national, I'm referring to EPSS, who is managing all supply chain aspects, and at subnational as well, we have EPSS hubs at regional levels as well. So those are already, we have a good visibility of the data. So the problem we have been mentioning is either at district or service point. So we can put it for debate whether we need a stock visibility at that level or not. But, Gavi also recommends at least high-level PHCs and districts to have stock visibility. So the thing is, we are supplying monthly, but whenever there are campaigns, we usually have leftover vaccines. That's why we wanted more how visible could it be, and then to communicate with, of course, the regional health bureaus would have their own way, but if it's visible for them as well, it will much easier their operation. That's why we're mentioning ELMIs.
I think my comment is, if the provincial and the district level have visibility to that level, that's good enough, because they will collect extra vaccine and they will identify risks as early as possible. Yeah. But for the national level, for us to have that level of visibility of the operational level, I thought it might be a bit too demanding, considering the 60,000 service delivery points you mentioned.
Yeah, so when I was mentioning the visibility both for national and subnationals to have visibility to their level, so at least we can have an interoperable system which either the nationals or subnationals can use it for decision making. So I was referring to that.
Great, thank you so much, Ethiopia. Let's move on to Zambia. Oh, before we move on to Zambia, do other countries have questions to Ethiopia? No questions? Okay. Elizabeth.
Ask my Ethiopian colleagues, probably they've answered this. The RI head for Nigeria asked this question yesterday. How are they sure that the health workers at the facility levels are actually compliant with the lock-up, don't use instruction?
Did you get the question?
Yes, a very difficult question to answer now. So whenever guidance coming from Ministry of Health specifically, most of the times they abide to the information, but it won't be consistent for sure, because so the issue I mentioned earlier, if I get exactly her feedback, so for instance I was mentioning health workers used to be very hesitant because of the guidance not to waste vaccines when we are using 10 doses, and then when we are giving opportunity to use for every child coming or for every child you get in the field to open. So such kind of guidance could be provided, and then they will be applied. So I think there might be inconsistencies among health workers. So this is from my experience and understanding, if I exactly answer your question.
Sorry, you were a bit far from the mic. So do I take it that Ethiopia has a strong monitoring and evaluation system that goes down to the healthcare facility levels? and we can be sure that there is compliance at the grassroots.
All right, thank you.
Yeah, so, yeah, I think, sorry. So I would say we're not bad on coordination because, for instance, we have weekly EPI monitoring. On that, all the regions will come and then present, and then they will also do the same to deliver those messages down to the health facilities. Mainly, the administrative structure is we have the Ministry of Health, Regional Health Bureau, and the lowest administration level is district. So they have that mechanism, and then we have a good human resource, especially the technical assistants are also very instrumental, who are embedded at regional health bureau levels as well. We also have TAs even at some zonal, but that's not as such functional. So, whenever there is guidance or anything which needs to go quickly to the district level, we use this coordination platform. Definitely, at least if the government focal is not able to attend that specific coordination meeting, they will assign someone or the DA could handle that. So they will present their status, they will take any guidance coming from the ministry. So Melkamu is making this weekly meeting. If he is not present, he will delegate as well. So, the act of delegations, taking things down to the health, district level, it's easier thanks to COVID. We have these online platforms that's becoming more easier for the coordination.
Wonderful. Thank you so much, Ethiopia. Let's now move on to Zambia. So first the challenge that you posed, and then the ideas that you got. Who is presenting from Zambia?
So for Zambia, our challenge was the suboptimal MCV2 coverage. So the suboptimal MCV coverage, so both MCV2 and also the one for the supplementary immunization activities. So what the suggestions have been from the team is around relaunching the MCV2. So I think trying to still remind our different stakeholders of the MCV2. So some sort of like reintroduction, just to emphasize that. And then also targeted engagement, awareness, and advocacy. Then community level advocacy, so engagement of various leaders, such as the religious leaders, to see how we could try the HCD approach. And then strengthening or targeting the second year of life platform. Yeah, so updating microplans, reducing missed opportunities for vaccination, and also community engagement. Thank you.
Questions for Zambia? Yes, Maggie?
Hi, Constance, thank you. I'm curious because the coverage gap between MCV1 and MCV2 has come up a lot in this room over the last 3 days. And I see the idea of relaunching the MCV2 platform. I'm curious about what the feasibility of that is and what challenges might come with it. And since we know with Zambia, the switch was, as you called, a silent switch, and it seems that the impact has been mixed, whether or not it would be feasible to also leverage that reintroduction of MCV2 to provide more guidance and a more structured approach to the measles 5-dose implementation.
Okay. Yes, I think that can be feasible. Firstly, I think there are also some health workers who think the second dose is a booster. So others still feel just that one dose. So I think that emphasis, and the good part is that we recently introduced the malaria, which is also being given at the same time as MCV2. So I think we'll try and utilize that platform, even as we emphasize that fourth dose of malaria, to also incorporate messaging on the MCV2. Thank you.
Great. Okay. So, looking at the ideas that you got, where do you think are they easy do you see them as quick wins or more complex to implement? Because it's important to not just think of ideas, but also think about, is it even possible for these ideas to exist and achieve the outcome that you want to achieve? So if you were to map them on that framework, where do you see them fitting in? I see. Oh, please use them.
Okay. They can be feasible, but they need to be tailored to the specific country context.
Mm-hmm.
So just as I mentioned the issues around malaria, so we'll try and see, okay, what do we have going on? How can we adapt this to see how we can use that to address the challenge you are experiencing.
Great. Any other questions for Zambia? No? All right. Then we're going to move on to Nigeria.
Okay, so thank you. Just trying to navigate this, sorry.
I'm projecting it as well, if you're struggling to see on your end.
It's not visible. That one is even. So for Nigeria, we had, wow, we received so many responses. This is really helpful, and some persons are still typing. So our question was, how do we effectively communicate the interim guideline, which we said we developed for how healthcare workers should mix the use of MCV and MR switch, especially just operationalizing it and getting the healthcare workers to also communicate and cascade this information to caregivers. So some of the responses we got were training and HCD to make healthcare workers part of the decision-making process and instill shared accountability. Consider using job aids, visual aids to help understanding and guide decision-making on what to use when. Consider development of job aids, okay, coupled with regular targeted supportive supervision and mentorship. Appoint healthcare worker leads, champions per district, sub-district, facility to translate challenges and current information. Link these healthcare worker champions also with community organizations to create awareness and demand. We're also asked to plan series of webinars with healthcare workers with simple topic each time to guide about the guideline, and also have weekly checks with all facilities via assigned interim guidelines ambassadors, healthcare workers, already at the facility and community level, and also cascade training beginning with national, then subnational into the district. I think all these are super helpful comments. We had started the engagement with the healthcare workers at the states and also LGA level. But what we wanted to even hear more was how they will communicate with the caregivers. The healthcare workers will communicate with the caregivers. And I think the visual job aids comes in very handy, because it's something we can even give it to them to say, this is why we are still using both antigens at this time, and it's a phased sort of approach that we're doing. But these responses are super helpful for us as a country. Over.
And how easy would it be to implement some of these ideas in your context?
I think it's quite easy. The trainings has been done as like they mentioned. I think the part where we need to design communication materials, IEC materials, and job aids, it's quite easy. We have an advocacy team in country, and they have all the sort of support, and they've been designing IEC materials, so it's not something that's quite hard to do. Yeah.
So you could start next week.
We've already started, but definitely we can put this to, yeah, we can.
Fantastic. That's great to hear. Elizabeth.
I don't think I see it on the board, and it's a little bit late for me to write it down, but they might want to include this. Have you considered the use of AI, to simplify a document? Because if I understand correctly, it's making those complex guidelines simple for the grassroots healthcare worker to understand, right? Okay, when we were preparing for this study, the consent forms that was submitted initially, the UCT HREC returned them and asked that they be simplified to the level of a grade 6 learner. And the way I accomplished that was by use of AI, ChatGPT to be exact. So if just an idea for you to consider, putting your complex guideline and ask it to simplify it and see what comes out.
Can you add it on the mirror? Can
you
add the idea?
Okay.
Yeah, I think you can add it on the mirror, but I think this is very helpful. But as a country, part of what we usually do is try to simplify even the messaging in local languages, as we have 3 predominant languages across the country. So even when we develop IC materials in English, we try to simplify it in their local languages so it's easily communicated in those rural areas where they can't speak English, but also using AI to further simplify how we present the messaging. I think it's something that we are happy to also explore.
Right.
Thank you.
Dr. Bolton.
Yeah, I was typing it as you were speaking, so maybe you didn't see it. But definitely regular supportive supervision is really, really critical because it gives the opportunity for on-the-job training of health workers, troubleshooting right on the spot with health workers who may be struggling on how to handle different scenarios. But how many people in this room don't have WhatsApp? Can you put your hand up if you don't have WhatsApp? WhatsApp. You see, everybody has WhatsApp. Okay, WhatsApp, I'm not paid by Meta, so I'm not advocating WhatsApp. But just to say, there are tools out there that networks of health workers utilize for communication. Yeah. And there is a documented experience of the use of WhatsApp in Cross River State, which we published with a number of colleagues in Nigeria a few years back. So this was in the context of campaign preparation. So all communication about the campaign organization, logistics, communication, day-to-day troubleshooting, guidances, and so on, within the coordination team was done by WhatsApp. Very intensive over a period of about 2 months, a month and a half. It turned out to be an excellent tool for people to reach each other instantaneously. So there are networks of health workers who use such communication tools and which can be used for instant messaging, one. Secondly, if they face problems in handling any scenario, I'm not an informatician and I don't have the skills there, but there are people who can help you put together a bot, a chat bot, which helps a health worker. I've come up with such and such a situation. How do I handle it? You don't have to respond from Abuja. The bot will immediately respond to them on how to handle these things. So let us try some of these approaches to be able to address issues. The other thing I wanted to say is Dr. Hassan, initially he raised 2 points. One was the communication, the other one was the challenges they have in operating. So if you'll allow me, I'd like to say a few words there. So for monitoring of data, the complexity that is created here is we use MCV for second dose, we use MR, monovalent measles for second dose, MR for first dose. At least the situation is going to continue to be like that for the next 8-10 months, from what we understand. Now, is that the end of the world? No. We are giving measles rubella vaccine in the first dose. And the reason why the country was guided to use it as a first dose was because first dose coverage is higher than second dose coverage, one. Secondly, the rubella component, only 1 dose is enough to attain 95-97% rubella seroconversion. It is the measles vaccine that needs 2 doses. And for the second dose, we use measles monovalent. In the end, the country is going to be reporting administrative data, first dose and second dose. Now, because second dose is measles and not rubella, we cannot claim that we have given 2 doses of rubella. But in addition to the administrative coverage, every April when the country provides their national data to WHO, UNICEF, JRF, there is an option for providing official coverage estimates. So administratively, you report what comes through, 100%, 120%, it doesn't matter. Measles, MR, as far as you know. But then there is an option for you to be reporting on what your official estimates are, knowing that you're using only one formulation for second dose and another formulation for first dose. So there you can plug in MR coverage, first dose is such and such. It cannot be beyond 100% because it is your official estimate. And second dose, you can signal that it is only measles vaccine that is being given in the majority of health facilities. Now, when WHO and UNICEF compute the estimates, they do computation for MCV1, whether it is MR, MMR, or M, they compute that as a measles coverage. Second dose for any measles-containing vaccine, monovalent or MR, and then they compute estimates for RCV1, which is rubella-containing vaccine 1. So there is no official estimate for second rubella vaccine dose. So there is no problem eventually in terms of what the global level estimates for Nigeria would say vis-a-vis your first dose coverage, second dose coverage, because MCV1 and RCV1 will be equivalent for this year where you're giving 2 doses. And then for the second dose, everybody knows you're not giving rubella, at least for this year. It is MCV2, in which case it is monovalent. So you are out of the woods as long as the administrative coverage reporting and your own estimates clearly show that first dose is MR, second dose is monovalent.
I think the challenge that the country has is more like from the internal vaccine accountability lens. Okay. So internally as a country, if we have all our data tools showing MR at the moment, so what you have at the facility is only MR. There's no MCV data tool to show that you're still recording MCV. And you still have doses of MCV at the health facility. You're expected to account for it. So healthcare workers don't even have the data tools that shows MC to account for MC. So it's more like you're using an ad hoc means to say, even if you vaccinate with MCV2, record it. Even if you vaccinate with MCV2, record it as MR. But when you now go to the DHIS2, what you still have there is MCV. I don't know if you understand. So
that's a different question, very complicated, and I have no answer for you.
Exactly, that's the point where we are.
Yeah, thank you.
All right, any other comments or additions to Nigeria? Yes.
How long will it take to update the DHSI tool? And maybe is it possible to just standardize it really quickly to everything MR, knowing that MR2 is MCV?
Okay, yes, thank you very much. The DHSI tool is not managed by the MPACD, it's under the Federal Ministry of Health, right? And we have, it's a national platform, not only for immunization, for other interventions. So we're in talks with them, and we're very hope that soon that will be done, not only for the MR, even for the malaria itself. So they continue to update the tools based on what you have introduced. That's what they do. So that will not be a problem. And again, Dr. Bacha, yes, I think we agree with what you said, and we look at how we can also make use of some of the comments. But as a country, I think we already provided our own thinking on how to manage the data. It was part of what we use in engagement of when we were engaging the state temporarily, because we know this will not continue forever. After 10 months, when we have exhausted the MCV 10, we go back to our MR for first, MR for second. So we cannot be changing data tools almost every time. So we have provided guidance on how to make use of these data tools, meaning that any figure we see under the MR2, that tally sheet or register, we assume is they use the MCV, because that is the instruction given to them. That's the assumption. But how are we sure? You know, there will be a lot of, it's complicated somehow. We just assume that any data we see under the MR2, we assume it's the MCV 10 they use, because instruction is that they use MCV 10 for second dose. That's an assumption. As he said, problem will now come when it comes to vaccine accountability. The vaccine tools, what they use at the lower level, say have only one column for measles. It doesn't have 1 and 2. So how are they going to do this? That's just a problem. We believe since it's going to be for the short time, after 8 or 9 months, we'll be out of that. Then we'll continue with our normal MR first dose and MR second dose. And also in the interim guide, we also know that it's complicated if we don't, especially even we at national level. We are not that even some of us, when you're trying to interpret what we have in the guide, some people always get confused when you're talking about give this one, because we have to start with the scenario that if a child have received routine MCV and he has not, maybe during the campaign, he received he has not received second dose of MCV, receive MR for campaign. Scenario is that what's he going to receive for the second dose? All those things look somehow complicated for those, especially at the lower level. So that's why we are trying to see how we can go down there, do a kind of face-to-face orientation, then with what Pacha said, supported supervision on job training will really help. Within a very short time, we are going to make use of these, the measles monovalent vaccine. Thank you.
Thank you. So we are now going to, if there are no additional questions or comments, we are now going to move to Cameroon.
So for Cameroon, it looked at the problem statement was around the pre-switch, moving from 10 to 5 dose. So the problem statement reads out as, how do we manage at the same time 10 dose vial and 5 dose vial? So we got some feedback around the problem statement, and which also some of the suggestions that came through was use of 10 dose for campaigns and mop-ups to reduce residual stock, and start with clear orientation and training of healthcare workers to use first use 10 dose and then shift to 5 dose. And then the other one was around how do we intensify community sensitization and also do mass campaigns to optimize usage of 10 dose vial to shorten the overlap period with the 5 dose vial. And the other one was looking at having systems in place to track stock at facility level and have guidance in place on what is used for routine and campaigns, and also to consider having a clear guidance for managing usage of vaccines close to expiry. And the last one was around use of community structures. So these were some of the suggestions. When you look at some of the suggestions, there are emerging themes around it, and I think one of the emerging themes is the campaigns, that we use the 10 doses for campaigns. So I think it's something that we are going to be taking forward. As we're doing pre-switch, I think Cameroon is ready for campaigns. So we are looking at using that residual stock for the 10 dose and seeing if it will then move us into the 5 dose before the switch happens. So happy to hear some more suggestions from the floor, or just to get more questions if we are moving in the right direction or not.
Yes. Questions, comments for Cameroon, additional ideas? Yes, Reverend.
I think this one is also a comment and a question. Just noting that solution as well, I think from what I heard from Zambia, is also an issue in terms of now you've switched to 5-dose. Like this may be a solution for when you're switching, but however, now down the line, when you have to have an MR campaign again or something like that, now you have another stock of 10-dose. The issue is that it still ends up having to go to routine to finish it up, otherwise it expires. So what is the solution for this 10-dose excess? Yes, you can forecast, but how well are these forecasts given that admin data and so forth is always off in terms of your denominator population? How do you actually have accurate forecasting estimates that don't lead you to have too much like underestimation or overestimation of your 10-dose? Thank you.
Did you guys get the question?
It sounded like a comment more than a question. So it's something to note about it. And I think one of the things maybe just to respond is with that forecasting, you look at massed campaigns and trying to make sure that what you forecast on matches the campaigns that you are targeting and the population that you are targeting. So it's something that the country would need to really look into as they're forecasting and targeting the population to see if there's a correlation and a match.
Okay.
Yeah, thanks. I didn't say this earlier. The point came up earlier today during the panel, but also during the Cameroon's presentation. So Cameroon sits at a really good spot now in terms of having this exchange and learning the lessons from other countries, the do's and the don'ts, so that they do it right as much as possible. One. Secondly, they have this nationwide campaign that's coming up around September, just before that switch is expected to happen, where they think they will be able to absorb any and all leftover 10-dose vials that may be during the campaign, which is again an excellent opportunity. But a point came up at some point the other day that even during the campaign, we may introduce the 5-dose in such a way that people who may have run out of 10-dose in a campaign setting can start using 5-dose. I think that creates a complexity and a challenge which has to be avoided as much as possible. Because one, in terms of the volume of management of vaccines and devices and everything, the 5-dose and the 10-dose are two different things. It will create a burden for the logistics of implementing the campaign. Secondly, monitoring the number of doses that have been used against the number of children vaccinated, because our tally sheets and everything are normally in a campaign setting designed thinking that we're using a 10-dose vial. Am I correct?
Correct.
Yeah. So introducing a 5-dose there will create some confusion, which makes it difficult for us to have a really good grasp of how many kids have been reached or not. So what I would advise is, let us use the 10 doses during the campaign setting, but not in such a way that we start chopping into the 5-dose in the campaign itself. So let's make it work in such a way that after the campaign, there is some sort of transition period rather than during the campaign.
So, Doc, maybe to ask a little, to poke a little bit into your suggestion and question. So, once we finish the stock, the residual stock for the 10-dose, can we then switch to move to using the 5-dose for the mop-ups, or will that still cause a little bit of confusion?
It will cause a bit of a confusion. I mean, hopefully we will not have huge volumes mobilized for mop-up purposes.
Yeah.
That it may be some exceptional districts that will have to do that. You can still do that, but knowing full well that the way you monitor the use of doses, the number vaccinated, will have to account for the 5-dose that was used for the mop-up, as opposed to the standard that we use for 10-dose. So it all depends on how good a grasp you have on the information, on the communication, on the logistics. It is doable, but it may be a challenge, because the way we understand it at national level and the way the operational level understands it, usually there is a disconnect. People continue to work the way they have always been working. When you introduce something new, it takes time for it to filter down, for them to understand why am I now using ABC as opposed to what I've been using. So just for you to manage it carefully. I'm not saying do this, do that, but I can foresee some challenges, and I wanted to make sure that. Thank you.
Yeah. So thank you very much for that remark. So I mean, again, like you mentioned, I think we're probably in the best position right now because we're learning from people who have done it, and we are about to do it. So, what I get from your suggestion, right, is to make sure that we kind of limit the campaign to the 10 dose vials, right? And it may be preferable to rather have a small residual stock of 10 doses left after the campaign instead of running out of the 10 doses during the campaign. Okay, yeah, so I mean the suggestion is it makes sense, it's well noted, and I think as we begin to refine our thinking on how to best do this, we'll definitely take that into account.
We have currently stock for 11 months in routine for 10 dose vials. And the campaign is planned to in September. It means that we will have extra dose of 10 dose vial for 2 to 3 months after the campaign. Yeah. And for us, it is again too long. What we are trying to do is to pay our co-finance dose to Gavi in 5 doses to use the dose we will have just before the routine dose we have to campaign, and then we'll have like 1 month of 10 dose vial after the campaign, and we can use it for mop-up. That implies that we have to do like a reverse logistics to collect all the 10 dose vials after the campaign to be stored at district or regional level. We are discussing about which store can stock the extra dose after the campaign so that it will be replaced immediately with 5 doses. And then we will select which district or which health facility can best manage the 2 presentations at the same time to send them, to push the 10 dose vial, the residual stock, not to all this health district, not to all health facility, maybe in 1 province only, so that we can have a good monitoring after that. I think this is one of the best reflection we are doing about.
Right. Any other thoughts, comments for Cameroon? For more ideas? No? Is everybody just waiting for us to finish so that they can go out of the conference room? Are you still here? Yes. Still paying attention? Yes. Okay, good. All right. I've just been informed that there is a questionnaire that is being passed around for people who are interested in going to the waterfront. So please write down your name because Naina at the back is organizing transport. So they need to know the numbers of the people that are interested to go to the waterfront. So if your name is not on the list, you won't be able to go. All right, so we now have 1 more country to go, which is Togo. So they have their challenge as well as some ideas that they received from the people in the room. So let's hear from Togo.
Ok, merci beaucoup. Pour le Togo, notre principal challenge est d'améliorer la couverture vaccinale en RR2. Donc, les propositions des uns et des autres sont ceux-ci. Le premier, c'est d'accentuer la sensibilisation des prestataires sur le calendrier vaccinal de la rougeole et d'organiser aussi des briefings réguliers des cliniciens pour les mettre à jour sur les calendriers vaccinaux. Le second point, c'est de fournir des indemnisations de déplacement, de transport pour les populations rurales vers les centres de santé afin de réduire les coûts indirects pour les familles. Troisième, utiliser les systèmes numériques pour le suivi et les rappels des rendez-vous de vaccination. Quatrième, utiliser les agents de santé communautaire pour le dépistage du statut vaccinal et l'orientation vers les structures de santé. Cinquième, encourager les mamans avec des certificats d'argent pour la vaccination RR1 et certificat en or pour la vaccination RR2. Sixième, envisager l'intégration avec d'autres programmes et renforcer l'utilisation des opportunités de vaccination. Et le dernier, c'est faire des sensibilisations de masse et réduire le gaspillage des flacons entamés en vaccinant les enfants, quel que soit leur nombre disponible. Merci.
Thank you. Thank you to Togo. And any comments, questions for Togo? Yes, Dr. Balch.
Merci beaucoup pour le Togo. Juste pour dire que il y a quelques années, on a fait beaucoup de travail pour encourager des pays, des programmes nationaux de vaccination pour faire un monitorage de fréquence et des raisons pour des occasions manquées pour la vaccination. Je ne suis pas sûr si ces jours-ci, il y a beaucoup de programmes qui font ça régulièrement, parce qu'il y a une occasion pour les mamans pour amener des enfants pour la première dose, mais vraiment on voit qu'il y a une drop-out, how do you call it in French?
Des perdus de vue.
Yeah. So drop-out entre la première dose et la deuxième dose. Et il y aura beaucoup d'occasions pour les mamans pour amener les enfants aux structures de santé, soit pour le monitorage de croissance, soit pour la supplémentation en vitamine A, soit pour les raisons de services curatifs. Et je pense que ça vaut mieux si nous faisons quelques études crudes, on peut dire, pour mesurer la fréquence et les raisons pour lesquelles on a des occasions manquées. Merci.
Okay.
Et avec ça, on peut donner des solutions très ciblées, je peux dire.
Okay.
Great. I believe that we have someone online that would like to make a comment. Please go ahead. Manzama, please go ahead and make a point. I can't see you.
Merci. Vous m'entendez?
Oui.
Please go ahead.
Oui, bonjour. Je voulais dire merci et félicitations à notre médecin qui est avec vous là-bas et qui a pu apporter certaines réponses en termes de propositions. Donc, comme je l'ai dit, je l'ai laissé dans le chat. Je pense aussi que par rapport au vaccin de 10 doses, on peut pouvoir les utiliser quand on fait les stratégies avancées ou les activités supplémentaires de vaccination, comme les journées d'accélération vaccinale, par exemple. on peut les utiliser pour qu'on puisse vraiment atteindre l'épuisement et éviter si jamais il doit y avoir des punitions. Maintenant, pour l'aspect des propositions à l'avenir, sur l'aspect communication spécialement par rapport aux communautés, nous avons prévu ici au niveau de la société civile l'élaboration des capsules vidéo sur l'achèvement vaccinal pour le RR spécialement. Parce que, comme je l'ai dit au début, le challenge au Togo, c'est que la deuxième année de vie n'est pas encore très bien maîtrisée par les parents. Donc, les parents ne maîtrisent pas très bien le fait, la nécessité ou bien quelle est l'importance d'aller à la deuxième année de vie pour la vaccination des enfants. Donc, on va élaborer des capsules et ces capsules ce sont les acteurs communautaires, les leaders communautaires qui vont parler dans ces capsules-là pour encourager les mamans, les parents à envoyer les enfants pour le RR2, parce que le RR2, c'est celui même qui souffre le plus au niveau national. Et donc, c'est un peu ce que je voudrais ajouter à tout ce qu'elle a déjà dit. Merci encore pour tout.
Thank you very much for your addition. Any other thoughts, comments, questions to Togo? Elizabeth, you look like you're about to raise your hand.
All right. Since you have helped me to raise my hands, I'll rise to the occasion. So I'm the one that wrote about the incentivize, and while listening to the interpretation, it didn't quite express what I intended to communicate by that. And so what I'm saying there is that when mothers bring babies for MCV1, which we know has a high coverage, they should get a certificate, a silver certificate, for MCV1, with the promise of when you bring this child back at 18 months, you get a gold certificate. So that a piece of paper is there. It incentivizes the mother to return because she knows that this is silver, there is still gold. So that's about my comment. Now, my question to Togo is this. Have you introduced or are you planning to introduce the malaria vaccines, which also, is a second year of life, vaccination? And do you intend to leverage that to increase your MCV2 coverage, which is the challenge? Thank you.
Ok, je pense avoir eu du mal à saisir la fin de la question. Si je résume un peu, Madame voudrait savoir quand est-ce que nous prévoyons introduire la vaccination contre le paludisme. Maintenant, la continuité, je n'ai pas bien saisi la fin de la question.
Has Togo introduced malaria vaccine, the malaria vaccine?
Oui.
Okay.
Oui. Oui.
Okay. The second part of the question is now, how do you intend or plan, or how are you, if you're already doing it, leveraging, that is, using the second year of life malaria vaccination to increase the coverage for MCV2?
Oui, c'est le calendrier. Il faut que je ne l'ai pas en tête. Donc, il faut que je vais vous revenir. D'accord. Je vais vous revenir.
Thank you. So no other comments for Togo?
Eric wants to respond.
Oh, please, Eric, go ahead.
Okay.
Ok, merci. Et pour la réponse à la question sur le vaccin contre le paludisme, oui, le Togo a introduit le vaccin contre le paludisme en septembre 2025. Donc, on a déjà eu à faire les premières, deuxième et troisième doses. Et selon le calendrier qui est retenu par le Togo, la première dose se fait à 5 mois, la deuxième dose à 6 mois d'âge, la troisième dose à 7 mois. Et nous avons placé la quatrième dose à 15 mois euh, avec le RR2 pour pouvoir profiter de ce vaccin contre le paludisme pour augmenter la couverture en RR2. Donc, en attendant, on n'a pas encore commencé à 4. Et ce que nous pensons faire, c'est de suivre la cohorte qui a déjà reçu les 3 premières doses pour qu'au moment où leur 4e dose va arriver, on puisse leur rappeler la date de vaccination pour la 4e dose afin de réduire le taux d'abandon entre la 3e et la 4e dose du VAP. C'est ce que j'avais à ajouter. Merci.
Thank you so much for the addition. Elizabeth, your question was answered. Okay, great. All right, so we have spent the last while identifying a challenge that you felt was very important for your own context. And then we got some ideas from the room to help address some of the challenges, and some of the ideas are already in, some countries have already thought about them, which I'm assuming is more validating for them to hear those ideas coming up as well from other countries. And since the workshop is about sharing experiences and learning from each other, so that was also another opportunity to see how others are thinking about the challenges that your countries are experiencing. And obviously the content from your country is downloadable from the mural. So you're able, these are your takeaways, you can take these ideas with you, and as you move forward with your journeys to plan or switching or reflecting on what has happened when you did the switch. So hopefully that will be valuable for you as you move forward. So, in terms of our agenda, things are moving quite a bit. Our agenda has become a bit of a moving target at the moment because we are trying to honor our promise of finishing early. And so as a result, some of the things are going to shift. There are some activities that we were planning to do after lunch. And I think it might be a good time now that we are still talking about the MCV switch, and we have ideas for the MCV switch related challenges, to then move over to Elizabeth, who is the co-PI of the study and has put together tools related to the MCV switch. We were planning to share these in the afternoon, but we are moving them now because we also have people online that we cannot sort of move their time. So I'm going to hand over to Elizabeth to take you through the available tools for the MCV switch, and then she will take your questions after her presentation. And then we'll see how we go. Hopefully we'll be able to do another session before we go to lunch this afternoon. All right, Elizabeth, over to you.
Thanks, Kenny. You can still call me Elizabeth, but once I put on my glasses, I become Dr. Elizabeth. So, joining me and presenting before me, it's someone who started out as a colleague, later became a friend, and is now almost a family member. So please join me to welcome Maggie and Paul from Linksbridge, and then I'll confirm.
But I've been put on the spot and I don't have a TechNet link here, so I need to sign in and it's a whole thing. Can you put it in the chat, please? Apologies. Actually, while I was thinking about this presentation, I was thinking about, because we're talking about tools and materials that are available for countries to use through the different phases of the switch process. And my sister Elizabeth over here was mentioning how it would be interesting to leverage AI for health worker training and put that as your chat prompt, make it accessible for a 6th grader. But I was also thinking about all the languages that we have across our countries represented in this room. And actually we have the 2 most linguistically diverse countries in Africa here in this room. Can you guess which 2 countries are the 2 most linguistically diverse countries in Africa?
Cameroon and Nigeria.
Cameroon and Nigeria.
Nigeria and?
Ethiopia.
Cameroon.
No, it's Cameroon and Nigeria.
It's Cameroon and Nigeria.
It's Cameroon and Nigeria. Okay, so how many, who wants to take a guess at how many linguistically diverse languages are in Nigeria?
200. About 250? About 250?
Higher. I don't know. Google told me.
What?
250.
280 something, 82, 85.
So maybe the AI system in Google isn't working well, but they told me 500 something.
500, exactly.
And Cameroon?
300.
Cameroon is like 250 as well.
Language is not that.
It's amazing. Cameroon was between 200 and 300. So
And then Google
that's the task you have for health worker training. Lauren, are you putting it in the mural chat? I don't. Oh yeah, that's what I meant. Oh, I see it. Okay. It works. Okay. This conversation about tools and resources available for countries hopefully will connect some different threads that we've been having about what, the journey map to switch. What are the different phases from making a decision all the way to implementation, monitoring, and evaluation? And at each step, as we've been discussing, there's a range of tools, materials, guidance, training that needs to happen along the way to ensure that the full system is, coordinated and prepared for the 5-dose switch. So the MCV, how many of you are familiar with TechNet and use it? So I think TechNet is sort of a centralized platform for EPI managers, but also for NITAGs and for global partners and technical assistants to share resources and materials on different aspects in global health. So if you go to TechNet and you type in anywhere measles, rubella, 10-dose, 5-dose, you'll find this resource page, which has a range of materials. It's organized based on the journey map, basically, according to 5 phases. The first is switch assessment and decision making. So, your country's still in the process of deciding and evaluating what are the benefits, what's the cost benefits, what's the impact on cold storage, what are the potential impact on coverage and wastage, who do I need to engage, how can I make sure that my NITAG is reviewing evidence and coming up with a decision, ultimately leading to the switch. But that's just the first step, right? That's kind of the easy part. Now we're we're getting ready to implement. And between when you make a decision and when the vaccine comes to country, there's a period of time, might even be a year, where you are preparing for that. You have the opportunity to ready the country with tools, resources, and materials and training to ensure that the country is ready to go when the vaccines are, when it's time to come. So the first thing is developing tools and guidance. If I click on this here, and it's just going to take me right there. So in this step, countries use the lead time before product delivery to prepare immunization systems for effective implementation. This is when you're doing those things that some countries missed, like updating EPI manuals, issuing notifications to health workers to notify them and inform them of the switch, of the time that it's coming, of the considerations that need to be thought about. This is an important one that we're seeing come up. Revising stock management, recording, and reporting tools so that you're tracking accurately what is the presentation that is being used, not just at the central level, not just in DHIS2, but on tally forms, on stock cards. All of these things need to be aligned in order for data to come in accurately. So what we have for each of these various considerations are materials which you can download. If you click, for example, I want to update my national EPI guidance, here's a template. It's generalizable, which means that you can make it country specific, including by adding your local languages, anything that's very specific to your country context and the way that you're managing the switch. So Nigeria's situation is very unique, right? We're using 10 dose for MCV2, 5 dose for MCV1. That needs to be clearly defined, and of course they've already done this. If you click on that, it'll take you to this page where you can click to download the link. You need to download each link. I'm not going to take you through that because I don't have time. Updating the multi-vial policy. So again, the switch is one thing, but if health workers aren't informed that because we are now using 5-dose vials, you can vaccinate at any time that a child is at the health facility, at a health center. So updating these materials and communicating them to health workers is necessary. Issuing notifications to districts and health workers. And by the way, this material about, it's generalizable, as I said, which means that each country can adapt it to their own context. We developed these through a range of materials that was shared from other countries, so it's kind of captures different points that we've seen. The next phase is around, socialization and preparing health workers through training. Here's when you have, and you're using standard training materials, scenario-based learning exercises, really making learning practical and hands-on. Job aids, we talked about that today too. What are the checklists for supportive supervision, for health workers to have in hand, for supervisors to have on hand, and planning for the delivery level changes and behavior change. So here we have a training of trainers deck that you can access, you can adapt, you can change. It's a PowerPoint. It includes those visual aids that we mentioned earlier today, which are so important, differentiating between the 5-dose vial and the 10-dose vial, which have different colored caps, and there's different visual aids so the health workers can easily reference it. And I can confirm what Dr. Hassan said, which is that Nigeria absolutely has already been doing this, because we actually developed this by working with the Nigeria team to think about what are the various considerations. Here's a set of scenario-based learning exercises that you can share with health workers at the facility level. You can include in those training exercises that include various different dimensions of the switch. So, going through what's the process of recording wastage versus vaccination. What happens if I have mixed doses in my stock? When do I use a 10-dose? When do I use a 5-dose? So all of these different kinds of real-world exercises are included here. And as I mentioned, we have job aids, which are checklists for health workers, supervisors, and logisticians that go through all the different points of preparation. In phase 4, your system is getting ready. You're aligning logistics, supply management, and service delivery systems to ensure a smooth transition. You're going to confirm delivery timelines, sequence distribution. We've heard from a lot of countries about the phased approach. So this is when you're coordinating across levels and minimizing disruption. Real-time stock visibility and close supervision are critical to prevent stockouts, avoid misuse, and maintain uninterrupted vaccine availability. So I think most people are familiar with the tools that already exist. We're not recreating the wheel here, but there's a range of resources that WHO, CDC, and others have developed already to help you manage these processes. And then finally, and this is where my colleague Elizabeth will come in a little bit more to show you some country-specific examples of what this looks like. You know, you've switched, now 5 doses being used, and what happens next? Do you just drop it, leave it, and hope for the best? If you're implementing a change, any change in your program, including ones that require investments along the way, you want to make sure that that program has the impact that you expect, and that you're able to see where are the gaps along the way so that you can intentionally target them and strengthen the systems to ensure that the investment that you're making is really worth the investment. So WHO AFRO has drafted a post-switch assessment protocol. This is the one that WHO AFRO, Dr. Balcha used for these country assessments, which he shared earlier today. That includes a post-switch data input tool. This is a really in-depth Excel-based tool, so low-tech, but carefully crafted, that will help you to assess various, monitor the impact on coverage, on wastage, on cold storage, on health worker behavior change, on communication to caregivers, all these different dimensions. We have risk assessment tools and other tools that have been developed by WHO AFRO. And finally, and this is where my colleague Elizabeth will join you to share more, there are some country-specific tools that have been developed over the course of this very thorough VACFA study, including an MCV health facility tool that was developed by our colleagues in Zambia, and an MCV household questionnaire that was developed by our colleagues in Ethiopia to help support the assessment. And so now I'll turn it over to Elizabeth to share a bit more about the other materials that have been developed for this project. Thank you, Simon.
Thanks, my sister from another mother. All right, thank you so much. I need my eyes to see. So, like has been said, and I was pleasantly surprised to see during Dr. Sidi Ndie's presentation yesterday that he also made reference to the Linksbridge TechNet page. So my work is practically done. So that's by way of introduction. VACFA is the unit. People get this mixed up. VACFA is the unit in UCT that houses NICHE, which you are more familiar with. So just to clarify that. So we had this beautiful study that we've been talking about for the past 3 days. And just as a reminder, the aim of the study was to conduct a comprehensive impact assessment impact assessment on the switch from MCV 10 dose to the 5 dose vial presentation prospectively in Ethiopia and retrospectively in Zambia. And our aim when we started out was to observe a 10 percentage point increase in coverage for MCV1 and 2 that would be associated or traceable to the MCV vial switch presentation. Just a quick overview of the study methodology, because that speaks to the tools that was used by the country. We had 4 objectives as requested of us by Gavi, and objectives 1 and 3. Now, in broad strokes, objective 1 is strictly quantitative. It spoke to the coverage, timeliness, session frequency, the likes. Objective 2 is strictly qualitative. It's basically a CAP study, a knowledge, attitude, and behavioral study for healthcare workers and caregivers. Objective 3 is the economic impact, is the objective that sought to address the cost-related material aspects of the study. That's objective 3, and it's basically mixed method, more quantitative, and then we have some open-ended questions on our questionnaires, and objective 4 was a bit of an outlier, and it keeps getting pushed out to the periphery. It's a light touch landscape analysis as requested of us, and it used a combination of literature review and primary study to explore the link, the current link between NITAGs and academic institutions. In other words, the evidence producers and evidence consumers, and to find out recommendations of strengthening the links if, where it exists. So what we did in the study was to provide the countries, both countries, with documents or tools that were already in existence. Like Maggie said, most of them were not, we didn't reinvent the wheel, and I'm sure my colleagues from Linksbridge can recognize their tools, on this list. So we gave it to the countries, to the two countries, asking them to go through, adapt to their context, whatever is applicable to their context, because even though the study is broadly the same, but the methodology differs, and they also came up with some other tools of their own choice. Like the Ethiopians said, oh, we just had a national vaccination coverage like 2 years prior, which will be around 2022. So they took some items and used that to develop the specific tools that they used in this MCV study. In addition to the tools that are already existing, my colleague, he will be coming later, Elton, also developed data analysis plans for the two countries, and all these tools were, recommended. None was strictly prescribed because the two study countries' contexts were different. So the final question, the final choice was theirs, but they did run it by us. And that will be to the right now. Is the list of tools that Zambia used for the study, and they also had training materials that they developed themselves as a country, and they used the modular form, and these are the materials that they did. And also Ethiopia, and I'm going to be honing in on Ethiopia the more here. They also had training. Both countries had like 5 days training, 3 to 5 days training of their health workers before deploying them into the field. And the first one listed here was the training manual for the Ethiopians. And then the tools that were developed, because of time, I'm honing in on Ethiopia, were in different sections, and they were loaded onto RedCap, which I will show you in a bit. But these are just the broad sections of the tool. I can't project all, and this is what it looks like. This is what the household data collection section on RedCap looks like. The entire tool itself is about 60 pages and everything, and we can't go into the details, but if you look to the left column, you'll be able to see other sections of the healthcare, of the household data collection that they used to get the quantitative data from the caregivers. And one thing also I'd like to just highlight here is the capacity of the RedCap software to also accommodate translations. You know, you can see that at least there were 3 different languages on that, on the tool. Then we have the health facility data collection tool. This is just a screen grab for you to see what it looks like. And every country will have to develop, depending on the question that you are seeking to answer, you have to develop your own RedCap data collection tool by yourself. But this is what Ethiopia did in this case. And the health facility data collection tool, this one speaks to the logistics aspect, some of the questions that were used or responses that were used to answer the health economic impact question objective of the study. And finally, there is another section which speaks to the human resource aspect of the health economic impact. This questionnaire were used to elicit responses that were used to answer the research questions related to the economic impact of the switch by the countries. And that's just about it. I would like to acknowledge the following people: Elton, the Linksbridge team, on whose tools these tools were developed, and the Ethiopian study team, the Zambian study team, my very own study team, and of course Gavi that supported the project. So thank you all. If there are any questions, the countries will answer them. Yes, Maggie?
Not a question, just another acknowledgement to Dr. Balcha and WHO Afro, who also developed many of those tools which were used in the project and helped to co-develop and refine and provide feedback for those tools. So really appreciate WHO Afro's support as well.
Thank you, and my apologies. Any other questions? Yes, sir.
Okay, yes, thank you very much. I just want to comment on the first presentation by Maggie, showing us the tools. I just want to ask where, because in Nigeria, when we are doing campaign and we continue to kind of improve on what we do every time we do campaign, we have what we deploy 3 months after having the activity plan. We have what we develop real time. We call it a readiness dashboard. This dashboard is being developed by our data team, and it has all the components of activities needed to be done before you can do campaign. It has the area of logistics, planning and coordination, AEFI, ACSM, and sort of what needs to be done, not only at lower level, but national level, state level, and also the AGA level. So this readiness dashboard is being used to track what is happening at all the 3 levels. National, what you need to do before you can say the state have not done. AGA, what you need to do. And we have, and this dashboard was designed in such a way that is done, designed weekly. Maybe about, when I say 3 months, that'll be about some weeks to when you say you want to start the campaign itself. And you're going to track these activities and their score. They are scored in such a way that at the end of the maybe 2 weeks yes, 2 weeks to the implementation, you must have scored 100% the way they designed the dashboard. So 2 weeks to the campaign, we now have what we call the go-no-go decision. As at that time, you are as a state before you can, because it's not just say we want to start by so-so date and everyone will start. You must be ready, and we must ensure that we track the activities. So 2 weeks or 1 week to implementation, we have what we call the go-no-go decision. So we now pull out the kind of critical activities that need to be done at all level, and with that, you must have 90% score. If you don't have it, that means you are not ready to score. I mean, you are not ready to start the campaign. So you are likely to have maybe a week or 2 weeks, depending on what is really ordering you to have less than 90% before you can implement. And I think this really helped in a way that, unlike before you want to start a campaign, you choose a date, and every state will just start the same date. So by the time you go for supervision, you realize that a lot of things are not on ground. So it's one of the tools we use and really help to improve the quality of campaign we do in Nigeria. Thank you.
Thank you, Dr. Hassan, for sharing that, and also for allowing me the opportunity to highlight the fact as well that each country in this room has their own tools, systems, ways of doing things that are complex. They've been thought out and refined over time by experts in your countries who are well aware of the situations and the gaps. They've been developed by people who know what's going on. So what's important about this here is we don't want to replace any of the tools that are being used. There's so many tools out here that partners are giving, and then now you introduce this one, now here's another thing. Definitely keep the systems that work for you and take what can be inserted along the way, what might be useful along the way, and adapt it for your own country's context. So what's here is basically an outline. You can take it, you can leave it. If your country is saying, okay, I have all these things in place, the logistics are ready to go, my tracking systems look good, but I need healthcare worker training documents to support this specific issue because we don't really, this is new for us. Then you can just go to the healthcare training. You can leverage this deck, adapt it, make it your own, put in your country's specific considerations, and use it, translate it, all of these things, and then use it for your country. The same with scenario-based learning exercises. These are templates, they're a starting place. If you want to use them, you can use them if you don't. But in addition to the opportunity to take or leave what you want, what this TechNet platform also provides is a simple view of that journey map. It helps you to kind of think about what are the different phases. And at each phase, what do I need to be thinking about? What are the things that I can't forget? And that I need to make sure that it's being communicated across different levels in the system. But I do appreciate how much work, Nigeria you have done this, you are the experts, and you have your systems. Dr. Balcha, I saw you wanted to make a comment.
Yeah, thanks so much, Maggie. So some of the things that we discussed over the last 3 days, the skill sets that are needed to succeed in what we want to do with the switch from 10 dose to 5 dose, they are not peculiar only to 5 dose. They are not peculiar to measles, rubella. These are EPI skills in general, management skills, management of a public health program for that matter. So there are a lot of tools out there that can be used as adjuncts to help mid-level managers, to help operational level people to understand the complexities and anticipate and manage them. So one of those that I want to mention is what we call the MLM tool. I'm sure many people are aware of this. Who has taken MLM or who knows the MLM course? Okay, I see that my Togolese and Cameroonian guys do not know MLM. Okay, so it is a training tool, currently resides on the web, but it can also be used as a training tool for a workshop kind of training, which contains modules on communication, on planning, micro-planning, logistics, monitoring, data management, everything that we've been talking about over the last few days. So we can help health workers at district level, at province level, at subnational level, to get that bigger skill set, to develop themselves in such a way that, and they can take it on their own pace, and at whatever level of prioritization, they don't necessarily have to follow all the modules. Whatever module that they think is relevant to their work, to the priority of today, they can go and take the module online, take the test, and pass it. It helps for health worker development as a tool for continuous medical education. But more importantly, when we have projects like this, it is one of the best tools we can introduce. So just want to throw that out. The second one is Immunization Academy. How many people are familiar with Immunization Academy? Yeah, excellent. So there, in Immunization Academy, it's available in English, in French, in Portuguese, in Hausa, and in Amharic, if I'm not mistaken. There are a lot of video clips, which are 2 minutes long, 3 minutes long, that try to explain some practical issues, practical skills. And these are very light clips that we can attach to a WhatsApp message and send to a wide number of health professionals in the field. So let us please use a combination of these tools as we work towards improving the outcomes of what we want to improve. Thank you.
Thank you so much, Dr. Balcha. I just wanted to re-emphasize. Actually, first, I appreciate all the tools that are out there. And just to circle back to the purpose of this workshop is to talk about the Gavi Commission study that we did and to disseminate our findings. So, yeah, it's impossible for us to use all the tools that are out there. And the question that Zambia was trying to answer, differed methodologically from the one that Ethiopia was trying to answer, even though it's the same question, but the methodology differs. So I think what I really want to emphasize here is that as all countries continue to plan, to prepare for the switch, know that there is no one tool out there that will speak to your specific context, except maybe with the exception of Nigeria that can just go there because, it was their tool anyway, and then pull it off. And I believe that at the end of the study, and it will be the tools that Zambia and Ethiopia also used will be made available, to the public, will be, put in the public domain. So if there are no other questions, I'd like to hand over back to Kenelwe. Kenelwe, please clap for Kenny. She's done a fantastic job moving around the agenda, doing everything. You're appreciated.
Okay, so continuing in the theme of sharing tools, we only have 15 minutes before lunch break. So we might have to continue this presentation that is coming up and then park it and then continue it after the Hexa Switch presentation. It's gonna feel weird, but hopefully you guys understand, because we are trying to make sure that we use the time that we have and honor the promise that we made to finish early as well. All right? So I am going to call Susanna No from VACFA to come and introduce you to yet another tool. There were some conversations yesterday related to evidence, As we all know, evidence is very important because you need evidence to make informed decisions. And this is hopefully gonna answer some of the questions that were raised yesterday, but also give you some ideas as well as to where to go to find the evidence. Susanna, over to you.
Okay. Good afternoon, everyone. I hope that you are all well, keeping cool in hot Cape Town, and enjoying this workshop. I'm happy that my turn has been forwarded to before lunch, otherwise it would have been called the graveyard shift. I'm Susanna, the librarian, and I'm talking to you this afternoon a little bit about my role in the MCV project. The last few minutes I would like you to use your laptops if you can, and I'm going to demonstrate to you step by step where exactly you can locate the MCV library guide, which was developed by Nish. So this is my brief agenda. In the next few minutes I will introduce you to the library guide on MCV and the reasons and methods used to create the library guide and continued updating of the topic. I will also mention the role and task of a librarian for such a project in general. And lastly, I will demonstrate to you how to access the Niche Library Guide. One of the objectives of the MCV project, as stated in the proposal to Gavi, is to conduct 2 literature reviews, one on the impacts on vaccine vial switches on routine childhood immunization, and the other on the impact of MCV switches from 10-dose to 5-dose vial on routine childhood immunization. Secondly, to produce a landscape analysis, followed thirdly by a protocol development, and fourth, the library guide. A core aim of the project is improving evidence support to NITAGs, and we as librarians act as knowledge brokers between researchers and policymakers as you are. Translate complex evidence searches into accessible formats, create curated library guides for decision makers, and train stakeholders in evidence use. This directly supports stronger, faster decision making. Why is a librarian good for such a project? What would the role be? Librarians are trained to develop search terms relevant to each question, searching of relevant databases, the exporting into reference managers such as EndNote or Zotero of the retrieved records. They are also trained to develop library guides, in the case particularly for the MCV project. They also use precise structured search strategies, advanced database tools, how to locate grey literature, and the searches would always be systematic and reproducible. Let's start with the literature searches conducted for a landscape analysis of NITAGs and academic institutions, as Elizabeth has mentioned, and consult NITAGs and partners through the global NITAG network, the GNN. The topic of the landscape analysis was the linkage of NITAGs and academic institution. And for the protocol development in phase 2, we produced a protocol reflecting on the literature reviews, consultations, and landscape analysis conducted in phase 1 of the project, including draft data collection tools, as you have just heard from Elizabeth and Maggie, journey map templates, and description of database management. On the development of search terms, in our specific case, the following search terms have guided our results for extracting relevant articles. We used the PICO model, identified the search terms where P is the population of interest, in our case the children. I is the MCV or other vaccines, that's the intervention. We compare it, the C is for comparison, the programmatic intervention, for example the switch, and O is the different quantitative outcomes like cost effectiveness and qualitative outcomes like, for example, the barriers. To adhere to these objectives, searches were conducted in several databases, including PubMed, Scopus, Web of Science, EBSCOhost, Google Scholar, and appropriate grey literature sources and unpublished reports. Reference tools such as EndNote and Zotero, which usually allows you to store all references in one place, group them into folders by topic or projects, add keywords and notes, and attach PDFs for quick access. And would also insert citations automatically while you write and generate bibliographies instantly, and reformat references to different styles in seconds. And it enables collaboration. So the benefits are therefore to use the services of a librarian, because the researchers are technical experts. You are all technical experts and can focus on analysis and interpretation, while librarians handle the evidence retrieval, database management, citation tracking, and knowledge organization. They also access global WHO and policy guidance papers, of course. So in summary, the project, the MCV project, produces lasting resources curated in EndNote and Zotero libraries, evidence repositories, library guides, and search strategies for future updates. And we librarians ensure that these are sustainable and reusable until after the project. So, with all this background understanding, Nish and the responsible team for the MCV project decided to create a library guide with these aims in mind for the stakeholders: to identify important search strategies, key databases, and grey literature sources. It includes non-peer-reviewed literature such as reports, government publications, websites, non-peer-reviewed materials like working papers, policy briefs, theses, and conference proceedings. They give quick access tools to key articles, data dashboards, and templates should be included, as well as policy and Ministry of Health documents, implementation plans and reports, vaccine switch documents, budget and frameworks. Of high importance are NITAG resources and best practice in academic links. And lastly, reference managers such as EndNote and Zotero to follow for resources that had been accessed. So this is what the niche library guide looks like, and I'm going to continue after lunch on how to show you what is in that specific library guide. That's all for now. Are there any questions? For 4 minutes. I rushed through this now because I was under time constraint. Maybe it will only make sense if you see the niche library guide. Elizabeth?
Okay, thank you. Thanks so much, Suzanne, for that presentation. I just want to ask the countries in the room, especially the NITAGs, how many of you work with librarians?
Librarian.
That's such a good question. Do you work with librarians in your countries?
No.
And if not, why not?
We have been trained by Niche to become a librarian. We know how to retrieve literature from different databases.
Use the mic.
We have been trained by Niche. Gilshad was in Cameroon to train the secretariat on how to retrieve literature, how to use sitting reference tool, and I know it is sufficient to be. Our knowledge in library is sufficient for the NITAG requirement. We don't have to be a trained librarian. Niche is already there for them.
I think, just to add to that, I think because it's not very common for us to have, librarians at our disposal to get this kind of work done, then the need for the training is just mentioned, right? Because in our context, we usually don't have the librarian. So the alternative is, building our own skill to be able to do some of that piece of work and to support the functions that, for instance, the NITAGs who need. Yeah. So I think it's the gap that's created the solution of, training teams to perform those roles. Yeah.
Okay, let me just respond to that. Thank you so much. I think that's as an indirect compliment to Niche.
Yeah, it is
But one of the things that we aim to do is to actually capacitate the NITAGs in a sustainable way. Dilshat was over in Cameroon for 5 days, and that was enough to get you started. But we want a continuity in such a way that we are working on, and I'm sure Dilshat will have mentioned this to you, on you, the Cameroonian NITAG, working with the Cameroonian librarians and not having to run down, to Niche, especially for local data. And that's one. And then secondly, what we have done for Cameroon, we aim to do for the 52 other countries. So to sustainability, is very, very core. And that brings me to my last point, which is objective 4, the linkage between the NITAG, which are the evidence consumers, as well as the academic institutions, which are the evidence producers. So for all the NITAGs that are here, please go back to your countries and try and establish a linkage, so that you can have support on hand. And of course, Niche is always there to provide more. Thank you.
Thank you, Elizabeth. Thank you, Elizabeth and Susanna. We are going to continue with the session after our lunch break. We have, as we agreed to a 30-minute lunch break. So we're going to take a lunch break now. And there was a request to take a group picture now as well. So eating into your lunchtime as well. So, no, there's no need for dressing up. You just need to show that you were present at the workshop. That's all that we're looking for, so don't worry. So can we quickly, have we decided where we're going to take the group picture? The people that mentioned the group picture, where are we going?
Outside, please.
Okay, we're going outside. So through this door, outside, there's an open area where we're going to quickly take a group picture, go for lunch,
come back, continue with the session.
They can follow me.
Follow Ben.
Follow Ben. Follow your own Ben. Can we take it in the meeting so that they can put on
You
the
can
videos?
take it.
Can, yeah.